ఇది ఆన్ చేసి ఇలా ఉండాలి
మనకు ఒక నోటీస్
అదే
ఇచ్చినట్టు ఉండదు. Hello. Yeah. Good evening,
How are you
sir.
all doing?
Yeah, fine, sir. How are you, sir? Hello.
Hello.
Yeah, Panjabi
Panjabi
sir.
sir.
Are we audible to you?
Good morning, sir. Vinod, sir.
Good morning to you. Good morning there. Yes,
Morning,
of
sir.
course. Hope I will be remaining awake for the entire session. This is 10 o'clock.
Yeah,
Just 5 to 10 minutes, sir.
Aditya, are you in really a hall or something? In a public place?
No, sir. We took a hall actually. We are the local people are doing it in a hall, so we don't have any interruptions.
Oh, okay. Okay. So kind of a,
Yeah, it's a big hall, sir, banquet hall or something.
okay. Okay. So you're really not virtual, are you? I mean,
It's a
it's a
kind of virtual,
common.
sir. Only people not from Hyderabad are doing.
Okay. That's the reason you're wearing the N95.
Yeah, yes, sir. Yes.
See that? Rajesh looks like he's on board without his video.
This thing. ఇదేమన్నా వస్తారా ఎవరైనా
తీసుకోండి
నేను తీసుకోనా అది దగ్గర ఉంటుందేమో మనోడు సారీ బస్
How are you doing, Rajesh? You growing some Corona beard there?
Yes.
I had
Corona
long hair
special.
until recently.
How are you, sir?
I'm very well, thank you, thank you, thank you for asking.
Hi,
How is the?
Abdul. Hi, Parthiban. I don't know the other
Hello.
two.
Good morning.
Welcome, Rajesh sir. I was actually calling you only. Right. Just 2 minutes, sir.
Yeah.
So shall we start, sir?
Yeah.
It's 9:35 already.
Yeah. Start on. Okay. Yeah. Okay. Just a minute. I think we can Ramanpreet. You can start. Yeah. This the first would be the free paper on the comparison of FHL and Peyronie's brevis. And following that, we'll be having Dr. Parthiban sir's talk. Yeah, we can go ahead now.
Hello everyone, myself Dr. Manasa doing post-graduation in Department of Orthopedics in PES Institute. My oral presentation is on tendo Achilles and the title of the study is Prospective Study of Functional Outcome of Tendo Achilles Reconstruction using Peroneus brevis versus Flexor Halsis Longus Tendon in Insertional Tendo Achilles Tendinitis Rupture. Coming to introduction, historically acute tendo Achilles tendon ruptures was regarded as a rare injury comprising less than 0.2% of general population. At present, tendo Achilles tendon is the most commonly ruptured tendon of the lower extremity and may account for up to 40% of all operated tendon ruptures. The increase in frequency is thought to be due to an increased interest and participation in recreational sports by middle-aged and older patients. Treatment of ruptures ranges from conservative management or percutaneous suture and open surgical repair to tendon transfer techniques. However, the choice is dictated by the type of injury, delay in presentation, tendon condition, and surgical expertise. However, the controversy rises in cases with insertional tendinitis rupture where there is no distal stump available for repair. In those conditions, the various treatment options available are transfer of the flexor hallucis longus tendon, peroneus brevis, peroneus longus, and semitendinosis. And other type of techniques is suture anchors assisted tendon reconstruction. The main aim of my study is to compare the functional outcome of tendo Achilles reconstruction using peroneus brevis versus flexor hallucis longus tendon in insertional tendo Achilles tendinitis rupture and to assess the superiority of peroneus brevis over flexor hallucis longus or flexor hallucis longus over peroneus brevis. Coming to materials and methods, the study was conducted in orthopedic department in PES Institute and a detailed history was obtained and the patients were subjected to a thorough clinical examination and relevant investigations such as X-ray and ultrasonography was done on admission and follow-up at 3 months and 6 months evaluated for healing and functional outcome by means of RUP and AOFAS scoring systems. The inclusion criteria is all adult patients of age more than 18 years with tendo Achilles rupture and the exclusion criteria is those with calcaneal fractures and with the previous history of tendo Achilles surgeries. The procedure for this study is all the cases satisfying inclusion criteria were included in this study and then by systematic random sampling and the study participants were alternatively included into either of the following two groups such as FHL or peroneus brevis groups. And this is the case of a 43-year-old male patient had a history of left tendo Achilles tendon rupture and this is the preoperative clinical pics and this is the preoperative X-ray and this is the intraoperative photographs showing flexor hallucis longus tendon harvesting and this is the final picture of closure and this is the postoperative X-ray and this is the final follow-up clinical photos. And this is the case of a 42 years old female patient who had history of right tendo Achilles tendon rupture and this was repaired by using peroneus brevis and this is the preoperative X-ray and this is the intraop clinical photos and this is the final postoperative X-ray. Unfortunately, when patient came to postoperative day 14 for suture removal after removing a slab, we have noticed wound dehiscence at the surgical site and for this we have taken a plastic surgery opinion. They advised a flap closure and they did transpositional flap and this is the final closure. Unfortunately, due to COVID pandemics, I have lost these patient follow-up and the assessment was done in this study by using a RUP score and a AVO FAS scoring system, that is American Orthopedic Foot and Ankle Society scoring system. And the follow-up of patients were done at 3 months and 6 months for evaluating the functional outcome of management by using a RUP and AVO FAS scoring systems. And the data analysis and interpretation is done by using Excel sheets and analyzed by using Strata 14.1 and a p-value of less than 0.05 was considered as significant and less than 0.01 is considered as highly significant. According to age of the patient and gender of the distribution, in my study, male patients are more prone for tendo Achilles ruptures when compared to female patients and depending according to the side, whether the rupture is on the left side or right side, the incidence is more on the left side when compared to right side. And this is the graph showing complication rates in FHL and peroneus brevis groups. And this is the post-operative follow-up score at 6 months showing a RUP score and AOFAS scoring systems. Coming to discussion, in this scenario, we have taken up the study to compare the efficacy and outcome of tendo Achilles rupture treated with the peroneus brevis and the flexor hallucis longus tendon transfer. In the present study, Achilles tendon rupture was seen at the mean age of 36 years and the incidence in men in our study was more common as compared to women, and this was in line with observations done by Lemmy et al. In his epidemiological study done on US population. And all the patients had unilateral ruptures in our study, which was more common on left side. Similar observations have been found by Chang et al., and they have attributed it more frequent due to left foot push off with the right hand dominant individuals. And in my study, 3 patients in a peroneus brevis group developed surgical site complications. Among them, one requires flap coverage and one requires debridement and secondary suturing. One healed with intravenous antibiotics, and 2 patients in FHL group developed a surgical site infection but subsided with regular antibiotic coverage. Finally, 6 months follow-up done on 24 cases in FHL group and 21 cases in peroneus brevis group by using a RUP and AOFAS scoring system, which shows equal result. However, in the study, I have taken a sample size of 61, but unfortunately, due to COVID pandemic, I have get a follow-up for overall of 45 cases, that is 24 in FHL and 21 in peroneus brevis group. Finally, the conclusion of this study is we did not find any statistically significant difference in the outcome between FHL and peroneus brevis groups, and both FHL and peroneus brevis groups are good methods with the predictable outcome rates. However, FHL may be preferred due to it can be accessed through the single incision, and it is more in line with Achilles tendon, and theoretical advantages of improved vascularity at Achilles tendon repair site. And these are the references. Thank you.
Yeah, we'll be taking the questions after the Parthiban sir's talk, and I think we can go ahead with the Parthiban sir's talk now. Okay. Yeah.
Good morning, everyone. I'm Dr. Parthiban, consultant foot and ankle surgeon and director Sri Hospitals from Chennai. In the first outset, I'll thank the organizers for giving me this opportunity to give a talk on tender structure, how to manage gap. In the first outset, the Achilles tendon is one of the most commonly ruptured tendons of the lower extremity. Chronic Achilles tendon rupture is defined as the ruptures that occurs in 4 to 6 weeks after injury. There's a break in the continuity between the leg and the foot. Tender-Achilles rupture, what are the risk factors? The most common in middle-aged athletes, previous tendon disorders like tendinitis, tendinosis, and peritendinitis. Age group is 30 to 40 years. Men and women are equally affected. Post-steroid injection for retrocalcaneal bursitis and drugs like quinolones. How the mechanism of injury happens, like pushing off with weight-bearing forefoot, extending knee, and sudden unexpected dorsiflexion of the ankle, like this. You can see this man, when he goes in for a going off phase, the sudden unexpected dorsiflexion of the ankle may cause a tender-Achilles rupture in a previously diseased tendon. And sometimes when there's a fall from a height, like a violent dorsiflexion of the plantar flex foot, and a direct blow to the contracted tendon or a laceration. So what happens in chronic tender-Achilles rupture? Large gap defect in tender-Achilles, defect filled by scar tissue, weakens the ankle joint and strength of plantar flexion and ankle dysfunction and gait disturbances. What are the problems you face? Large gap defect, scarring of the surrounding tissues, retraction of calf muscles, and loss of contractibility of the triceps surae. Clinical features will be pain, fatigue, ankle stiffness, walk with a limp, unable to run, climb stairs, not able to stand on tiptoes, and a lot of loss of the plantar flexion power. Clinically, when you examine the patient in prone position, edge over the feet, you will be able to see the palpable defect in the tender-Achilles and tendinitis. You may be feeling the thickness of the tendon there. And everyone should be knowing about the Thompson test. When you squeeze on the tender-Achilles, when there's a defect, the foot doesn't move. But when there is a normal one, the foot goes in for a plantar flexion. And investigations like radiograph will show you the avulsion fractures, the insertion with marked separation of fragments when there is an avulsion of the tender-Achilles. Or an ultrasound is a very inexpensive tool and a very simple one, and a dynamic examination is possible. When you move the ankle, you can see the break there. and the best to measure the thickness and the gap, good screening test for complete rupture. And MRI is another very useful tool for diagnosing Achilles tendon rupture and the integrity of the Achilles tendon stump, and assess the size of the defect in tendo Achilles, and post-operatively acquire the information of Achilles tendon healing as well. And see the defect in this. And management of tendo Achilles rupture. Goals: optimize gastrostomy strength and function, restore the muscular tendon's length and tension, avoid ankle stiffness. Conservative management: no role of conservative in chronic tendo Achilles rupture with a gap. And how you manage overall picture. Defects of 1 centimeter or less, a direct end-to-end repair without augmentation. 1 to 2 centimeters muscle mobilization with augmentation. Defects of 2 to 5 centimeters, VY plasty should be a good one. And defects of more than 5 centimeters, tendon transfer to fill the defect, FHL or a turn down. Direct end-to repair, you should be knowing a lot of techniques are there, Bunnell's, modified Kessler, and many techniques are available for this. And muscle mobilization with augmentation with plantaris tendon. That is the one. And VY plasty. It is like an inverted V where you make it at a cut at the muscular tendinous junction here, and you slide this and close it like a V on the top. This is how you do it. And the next is going to be FHL transfer and with a turn down. This is another technique how you do it. Why FHL is a first preference? It's close to the Achilles tendon, same function as triceps array, adequate strength, same axis of moving with rendo Achilles. I'm going to show you some few cases for this. This is going to be a case one of 45 years male presented with complaints of difficulty in walking and running, 6 months duration. On examination, a palpable defect in the tendo Achilles and tendinitis, inability to stand on tiptoe, and common sense positive. You can see the defect after excising all these tendon, the degenerated material. Usually to say it looks like a crab meat. You remove all these tissues, scar tissues, then the defect, then you plan in what you're going to do. This is one of my earlier day cases when I did a turn down. This is how this is done. And this is a case two. It's a age 49 years male, complaining of pain and wound in the left retroclavian since 1 month. Trauma to left heel. It's a very trivial trauma 1 month ago, and complaints of discharge from the wound. Inability to bear weight over the left lower limb. An ulcer 4 into 3 into 0.7 over the retrocalcaneum, exposing the avulsed calcaneum through the ulcer and necrosis of the surrounding skin. Seropurulent discharge from the ulcer and Thomson test positive. Left ankle restricted and painful. This was clinical picture, how it was looking like. You can see the X-ray there. There's an avulsion there. And the treatment plan was stage 1, we did a wound debridement vac dressing application, left retrocalcal region. Stage 2 was a calcaneal fixation, VY advancement, gastrocnemias, and reverse sural artery free flap. This is how we did it. You can see the defect in continuity. We did a reverse sural artery fixation like this, and did a VY advancement and a reverse sural artery flap, and did a closure like this. This is how it went on to heal. This guy is doing extremely good. And this is another case of a 55 years old female with chronic tendinitis of tendo Achilles, presented with some difficulty in walking, 12 weeks. On examination, a palpable gap in the tendo Achilles, not able to stand on tiptoe. You can see there is a gap of almost around 7 centimeters after excising all the devitalized tissues. And the FHL, this is a short FHL, which was harvested, and it was fixed with the tenodesis screw down. And how the tendo Achilles was put back. This case was, I should thank Dr. Ajoy for his case. There's a case for sustained injury to ankle 7 months back, trivial injury, diabetes mellitus, hypertension, defect in tendo Achilles, not able to stand on tiptoe. You can see the gap there. After debriding everything, it was a semi-tendinous graft. This is Dr. Sampath's case. Thanks, Dr. Sampath was giving his case. And this is how we did a tunneling on the calcaneum, and the cementary tendon was brought back and fixed like this. These are the options, what is available to augment a gap in a case of a tendo Achilles rupture. And the rehabilitation protocol for tendo Achilles rupture, 0 to 4 weeks, posterior splint, non-weight bearing with the crutches, hair cast, walking boot with 2 centimeters heel lift, protected weight bearing with crutches, active plantar flexion and dorsiflexion, and dorsiflexion and to neutral. Inversion eversion below the neutral level. At 6 to 8 weeks, remove heel lift from boot, weight bearing as tolerated, dorsiflexion stretching slowly, graduate to resistant exercises, proprioceptive and great training. 8 to 12 weeks, wean off boot, return to crutches and gradually wean off. Continue to progress range of movement, strength and proprioception towards retrain strength, power endurance and sports specific training. And the take home message is going to be chronic tendosclerosis with gap is complex, challenging condition. Management depends on the patient's age, demand and size of the defect. No role of conservative management. Earlier the management helps to prevent ankle dysfunction and gait disturbances. Thank you.
Yeah. No, I think the forum is open for the questions. Anybody?
Kamlakar, can I speak?
Yeah, sir.
Great talk, Parthiban. You covered a lot of ground in a very short amount of time. Obviously you're right, conservative management does not work if the person really wants to get their push off and things like that. But there are some patients who can get away with it, like diabetic patients, neuropathic patient or diabetic patient. I really don't want to do any reconstruction there because having a rupture sometimes is a blessing for them. So they overload the forefoot much less after having the rupture. So those are the kind of patients I will shy away from. There's one tip I want to share, and this tip is very important. I learned over the years. Even if you want to do an end-to-end repair, after 4 weeks or 6 weeks maybe, or even a small turn down flap, what you should understand is sometimes soft tissue closure is very tight, right? What can make it easy? If you incise the fascia, deep fascia, which covers the FHL, even if you're not touching the FHL, just incise the fascia all the way underneath, it's much easier to close the soft tissues on top. You understand? You showed a great case wherein the soft tissues were really stuck. The lady had, contracture of the soft tissue. Over time, at the site of rupture, the soft tissues contract. And once you repair, the tendon becomes very tight. And you're trying to drape the soft tissues over the tight reconstructed tendon, sometimes it's a struggle. So if you incise this deep fascia, everything will come together. That's the comment I want to make.
Okay, if you release the deep fascia, it becomes a little free. Is it?
Easier to close, you see, because the soft tissues will come away. So the deep fascia, which is covering the flexor hallucis long, it has to be long enough. It has to start proximal to the rupture and then end all the way up to the calcaneus. Then it makes it easier for it to close.
Yep. Yeah, I agree with Vinod. In my first, hey, how are you guys? In my first year of practice, I did FFL tendon diabetes patient, and I made in severe plantar flexion, and the patient came at 2 weeks with the skin necrosis, So on top of that, if I'm not doing the VY plasty or turn down plasty along with the tendon transfer, I do the gastric recession to take the pressure off from the skin. So, yeah.
So, I have a small query from my side. If you are doing an FHL, so what would be it's like putting in a wire screw, it is fine. But if you want to tunnel it through the calcaneum, so what would be the entry and exit points for that?
Are you talking to Parthiban or anybody?
Anybody, yes, all the panelists.
Sorry, Kamlakar, I'm unable to hear the question. So
you
the
can
tunnel,
go ahead,
you're talking about where should the tunnel be?
Yeah.
It's a great question, Kamlakar. That's a great question. So if I'm using the FHL and tunneling it through the calcaneus, I choose a point which is the most posterior and most superior, most posterior and superior. Superior because, I want to maximize on the length because, the way I do it, I incise the FHL at the crease, just distal to the crease, actually plantar aspect of the IP joint of the great toe. I incise it there and I incise it at the knot of Henry and bring it on. I have a long length. So this tunnel is most posterior because you want to increase the lever arm. Okay, so and superior to increase, maximize the length. Obviously, you should not be so close to the cortex, it might, give up. But having said that, you see, even in patients with a Haglund's deformity, when I excise that sharp edge, because the tunnel is going from medial cortex to the lateral cortex, it is a very sturdy tunnel. What I do is I start off with a small drill and I expand the hole, not by increasing the size of the drill, because the drill will cut out the cortex and the cancellous bone. So instead of using a drill, I use a smooth a awl to expand. So basically the cancellous bone is being impacted within the tunnel until I get the right size. So the incision is a percutaneous incision on the medial aspect of the calcaneus, and then a bone tunnel exits to the lateral aspect of the calcaneus, and loop it back to itself and have a long length to bridge the gap as well. So I have two motors, not only the gastrocnemius soleus complex reconstructed the gap by this excess tendon, and also FHL. So it is a very powerful, and it has worked very well in my hands.
So, Dr. Vinod, would you go for a long FHL? You recommend long FHL all the time, or only when you have a big gap?
I use it, I have been using it for all the time, because
Why long FHL? Why not the short FHL?
so basically when you harvest the FHL anyway, so you're losing that power. FHL, what does it do? It provides the plantar flexion strength to the IP joint, basically, because you have the FHB driving the MP joint at the first rate. So it's like robbing the Peter to pay Paul, so you already have the length. And most often, if you excise the unhealthy portions of the Achilles tendon, you end up with a gap 4 to 6 centimeters. Most of these patients don't come at 4 weeks. Most of my patients come at 8 weeks, 3 months, 6 months, a year sometimes. So if I just have a small gap, and if I don't need FHL, then I won't. If I need the FHL, it means it is a long enough gap for me, and then I want to use this tendon, the excess length, to maximize on the plantar flexion strength at the FHL. I mean at the ankle. And there are studies, even in athletes, the IP joint loss of function in the IP joint is not even realized. Some of the patients don't even know that they can't move the toe until you put the feet together and say, "Oh, look at that! I can't do this." Oh, I did not realize that. So I don't think it's the morbidity is as bad as if you compare to the Pernus brevis. I don't know semitendinosus. If you take that out, how much of a strength it will draw, due to the plantar flexion, but I suppose it will at least restore what he had. But I think, having another motor will certainly help it. If I'm sacrificing some tendon, I will rather sacrifice FHL. Because right there, as the previous speaker has told us all, it's very easy, accessible, same line, phase. There are all advantages. It brings in the blood supply too. Again, releasing that fascia on the FHL will bring that FHL closer to the unhealthy portion.
So coming to the very basic part, the most of the problem which the beginners would be having is with the wound issues with the tendon Achilles repair. Do you want to give any tips on that? How to go with the incision? I want to hear from all the panelists whether the incision would be straight posteromedial, midline, or when it goes curved, or what would be the preferable things for each other.
So if you look at the blood supply of the Achilles, the angiotome shows like the skin angiotome shows like medial and lateral is better. The posterior most is the worst, but majority of the orthopedic surgeon, foot and ankle surgeon, they go with the posterior incision. But like the only thing I do differently, I don't undermine the incision. It's more like that that you need to preserve the paratenon, and I'm using more like a no touch technique here. So basically without undermining the incision, pretty good closure of the parachinon, not to do the what we call like, you keep on poking into the tissue. I'm doing more of the sharp dissection. That's helping me to stay away from the complication. And second thing that helps, like if my patient's hemoglobin A1C is less than 7.5, there and then I do this surgery, reconstruction surgery, non-smoking, non-diabetic, I mean diabetic less than 7.5, there and then I do this surgery. As Vinod mentioned, like, if the patient is smoker or uncontrolled diabetes, give them AFO, patient can live without the Achilles tendon.
So, the point which Ashish mentioned is extremely important. Do not ever undermine the subcutaneous tissue. I go midline, vertical, all the way down to the tendon. There's no other structure which you can damage, except the sural nerve as you go more proximal. So straight down to the tendon. And then, again, I want to repeat this because it's next time you guys do this Achilles tendon repair, if you're not using FHL, even then, I advise you to incise this fascia all the way. It has to be long enough. The incision has to go way up underneath, all the way. If you incise, the whole soft tissues become easier to close. And if it's easier to close under low tension, then there's a less risk of wound failure. Thank God, I don't see that in my practice. So I know wound failure is a big issue. You may have to involve plastic surgeons, like, you showed a great case, Parthiban. So, but if you pay attention to technical details, don't mess with those flaps, and go right down to the midline, deep incision there, the wound should heal.
True. I mean, I think even with the number of cases which we have done in midline, I don't think we have had patients problem in the wound healing with the midline incision. It is just that the point always to be there's no dissection in between. So I think worldwide it is the same. If you take care of your soft tissues, they take care of your wound. I mean, so that is what the problem the take-home message would be in that.
So Parthiban sir, your take?
Yes, sir. Sir, I didn't get your comment.
No. What is your take on the incision part?
Incision.
Yeah, except with Dr. Vinod and Rajesh and Ashish things. It's the midline incision, what I usually go. You don't undermine any tissues directly to the tendon, and handle the things as gentle as possible. Using a non-tooth forceps, in fact, it's much safer. And usually I tell my assistant not to keep pulling too much on the skin there. And I usually close the skin by myself. I don't give it to anybody to close it.
One last one. There is a common practice here in the South Indian part where we do a pull-through suture through the tendon for the avulsions. So I think still it holds. Any experience on that?
Button under the
button technique. Yeah.
Button.
Oh, you mean
a tunnel through the calcaneum and a button under the heat.
Are you all talking about the acute rupture?
Yeah.
Oh, that's an acceptable thing, but there are other ways to pull the proximal end of the tendon closer to the distal end. And people use suture anchors, but if there is no damage to or pressure necrosis under the heel, and if it works, then there's no reason not to use it. I think it's a great method. So it is an established technique. People who use suture anchors, they have moved down from we do this percutaneous technique, right, by acute ruptures, wherein they use this instrument to bring the ends together, secure the ends and bring them together. You can use that, but only in the proximal end. Secure the proximal end and drag it through the paratenon, and then end it underneath the plantar aspect of the heel. Basically, all you're trying to do is bring the ends together and keeping them there.
The purpose of asking the question was that most of the time these patients come back in around 3 months' time with a complaint of infection actually. And when we go with a CT, we'll be seeing there is infection all around the suture tract in the calcaneum. Unless that is out, that infection doesn't settle down. So that was what is the technical issue or some post-op rehab, there is a problem in that.
I mean,
I
can
mean,
I
I was
put in a word? The thing is, I think if you're putting the button down, then I think the wound management is of paramount importance. The problem here is we in India have got a lot of dust. We are exposed to a lot of problems here. So if you are putting a suture button, or if you, I mean, anybody puts a suture button, that's fair technique. The technique is fine, but the post-op care is something which is very important. Uh, that is what the message would be. Otherwise, if you're not very sure about that, then as I mean, we've all migrated towards suture anchor, and I think suture anchor is way to go if you are in doubt about the patient's, you know, how the patient would be in the post-op period.
yep. Yep, I agree with Rajesh. Like, I was trained by old school surgeon here. He was always used to do button, and even in states, I used to see some infection. I mean, it's been great technique for the pediatric population, but if you have option of going without it, you should try to do without it, you know. And or if your patient is compliant and can come in the follow-up on regular basis, then you can use it.
So can we move ahead to the next talk, sir?
Yeah.
Yeah.
Sir, can I ask a small question, please?
Yeah.
Between interference screw and anchors, how would you decide? Is there any difference on the strength, or you can early rehabilitate? How do you select between a suture anchor and an interference screw when you have the option?
I mean, if you have interference screw available, right? So
Yeah.
most of the time, like I do the mostly the short harvest for the small gaps. So with the short harvest, like you don't need big tendon, and you can do like secure it very easily. And when you look at the literature, it showed more like pull out strength is better with the interference screw than the suture anchor. I mean the other technique, okay? So that's the thing. There are a number of times, like if issue of availability and stuff, then you can do the drill or tunnel or suture anchor, then you can use that.
Okay, thank you, sir.
So we'll be proceeding to the next talk by Dr. Ashish Shah. It is the gastrocnemius, a friend or foe.
Hey guys, this is Dr. Ashish. I'm from University of Alabama, Birmingham, US. I'll be going to talk about the gastrocnemius, like which is pretty close to my heart, or it's very common in my practice. I was at the Oasis Cone in Manipal about 3 years ago. Sorry to miss you guys seeing in person, but thank you for the opportunity and being part of this conference. So anatomy of triceps suri, it comes as a gastrocnemius. Medial and lateral head of the gastrocnemius arises from the medial and the lateral epicondyle, and it continue as a one big muscle belly, then the fascia underneath, and it comes as a soleus, also comes arises the and runs parallel to it. If you look at on the side, like on the laterally, there is a sural nerve, and there are so many variation of the medial branch, lateral branch, but it runs parallel lateral. That's one of the most commonly injured structure or stretching of the nerve. We will talk about in the further slides. And if you look at the different level of like straight procedure, Bauman or Valpillus, you can see on this Achilles tendon or the triceps suri, which continues Achilles tendon and inserts the posterior the Achilles posterior the calcaneus. So gastric tightness is very common. It's a pretty hot topic, uh, specifically in the last 5 to 7 years in the foot and ankle world. We look at the heel pain, patients with plantar fasciitis, Achilles tendinosis, patients with a forefoot pain, metatarsal, Morton's neuroma, forefoot ulcers, diabetes, diabetic ulcers, asthmatitis, or it can be the adjuvant procedure with the posterior tibial tendon dysfunction, maybe with the KO varus, or number of comorbidities. And number of times the patient with the delayed presentation of the tongue type fracture of the calcaneus or irreducible talus also, we give consideration of the gastric tightness and stuff. So it's very important to check the gastric tightness. Like, we basically, we, we pull up the, I don't know why am I not able to run the video here, but it's basically, think, yes, when you see the gastric tightness, what you do, with keeping the knee extension, you bring the dorsiflexion of the foot, keeping the heel in varus, locking the transverse tarsal joint, and you ask the patient to flex the knee. And if patient, when they flex the knee, there should be more dorsiflexion. But if it's not, if it's more dorsiflexion, it's coming from the gastric tightness. If it's not, it's coming from the Achilles tightness. In this video, you also saw there was a what we call the forefoot calluses in this patient. That was also the super imposed tightness or overloading of the forefoot region. Gastric tightness, this is like one way of checking. You can also keep the patient in the prone position and check the tightness of the Achilles. So all of these patients, they undergo conservative management. There are 100 different ways of stretching gastric. I tell my patients, like, that here we are stretching the left leg. The left leg goes away from the wall. The leg that you need to stretch, you keep your knee and hip extended, and you do a little pigeon toe. Basically, you lock the transverse tarsal joint by inverting your forefoot here. And by inverting the whole foot, now you flex the knee, flex the hip of the opposite side, and you keep your knee and hip extended. This is recommended by the American Foot and Ankle Society, that you will feel the pull coming all the way from the knee, from the origin of the medial and lateral gastric. Number of times patients have the tightness coming from hamstrings. They feel like pull coming from all the way from the hip. But this is the most common way. I tell my patient, this should be the part of the routine of their life of gastric stretching. They should stretch at least 2 to 3 times a day, and for 3 to 4 minutes at a time. If this patient fails with the conservative management, we give trial of at least 6 to 9 months before saying failure of the conservative management. We go with the proximal release or gastrocnemius recession. I offer them for the plantar fasciitis or Achilles tendinosis. Proximal release at the knee level, but either it's a Strayer procedure, Baumann, or Volpilis procedure. So basically, from musculotendinous junction up to it starts Achilles tendon, any level that you release, the literature says there is no difference, and I was able to find in my practice as well. So basically here at the musculotendinous junction, I separate it out, after releasing this proximally here, then after separating the neurovasculatures, you can see that after releasing the paratenon, this is the difference. Like soleus is a pretty flimsy fascia there. Okay, this is, you can see more like a plantaris tendon number of times, but now you start releasing the gastric here, but you don't release the fascia posteriorly. Very important, that you release this. So post-op protocol, all of this patient with the gastric recession, I do posteromedial incision. I don't try to look for the posteromedial junction or the Strayer. I cut at any level at the posteromedial place. Posteromedial incision, you can do the pneumatic walking with the boot on the same day or the next day, switching over to supportive shoes or regular shoes when they feel comfortable, and they do the home exercise program. There are a number of people or number of surgeons, specifically I have noticed in the European or the South American region, they do the proximal release, and they do just release of the medial head of the gastric, and it's supposed to make the less the less weakness. I've not done this. I'm able to recreate the results, reproduce the results with my Strayer or Baumann or Welpilus procedure. So I have not attempted, but that can be, this is basically medial head of the gastric. You can see that the fascial layer that's released there. I pull up like these are the papers like that we publish more of the data from my first 4 or 5 years of practice, and I wanted to see that how these patients were doing. So we published in this overweight in obese patient for the plantar fasciitis. It was more like a retrospective series, 25 hills, 24 patients. Average duration was like 17 months. And you can look at the BMI 34.4, basically average of like 100 kilogram. You can see we did chart review, telephonic review, and we check all this patient. They tried conservative management for 6 to 9 months. And same thing, we check silver score test and stuff. Average follow-up, as I mentioned, 18 months at a time. We did the VS and the FFI score, and we asked the different questionnaires and checked the strength and stuff. So if you look at the pain score was reduced from 2.5, 8.5 to 5.4 to 2.54 post-operatively. Same way the FFI score was improved dramatically in these patients. And when we asked this patient, they reported total of significant pain relief. Only one patient who did not achieve the significant relief, because that patient was done, the surgery was done under the regional block, and patient got the foot drop. That was like, it was the most bizarre thing that I noticed. And they got the foot drop secondary to this regional block. But all of this patient, more than 80%, 79% say, hey, they would definitely go for the other side, or they would recommend to other patients. The return to work, 83% where they were able to return to work. And basically, time to walk in a boot was like not just less than 4 weeks. Time to walk out of the boot was 7.3 weeks, and they were able to return to work by 10 weeks of mean. And BMI, as I mentioned, it was pretty high BMI. This 12 patients report the subjective calf weakness. In the first 3 months, they have the difficulty with the stairs, difficulty walking, doing the sports. So that's why if my patient is a runner or doing competitive sports, I'm very much careful. I offer them 10 different options before going for the gastric recession, and because they have the transient weakness, and I don't prefer to do this for my competitive sports, which we have seen in the literature as well. Complications, these patients have transient neuritis, but all of them recover at 6 weeks interval, at 3.5 months interval. So I saw the pseudo neuritis, which is pretty common. I say, hey, does it make any difference? So we did the 10 pairs of cadavers, and we checked basically, if you look at the first figure, what we did before doing the gastric recession, we tie a knot at certain distance on the sural nerve, and slowly, after releasing gastric, we slowly did more dorsiflexion. So assuming the patient with the severe equinus contracture, severe tightness, they will do more stretching of the gastric. So in those patients with the severe, when the dorsiflexion was extreme, more than 90 degrees, we were able to see the distance between the sural nerve was increased. I mean, the distance between the knots on the sural nerve. That tells you get higher sural neuritis possibility because of stretching of the nerve fibers. And this is, I've seen commonly in my practice when my patient with severely high BMI or severe equinus contracture. There is a harder way. I can't, I can't check the tightness subjectively, but I was able to see that severe tightness, and they're getting more of the sural neuritis. So this paper that we publish, it tells, oh, more tightness, possibility, there are higher chances of sural neuritis. When looking at our results with the plantar fasciitis, I started doing for Achilles tendinosis. And specifically, I did for my patients more of the higher BMI or the older patients, sick patients. And this is, I'm talking in the first 5 years of my practice. And in the last 5 years, I offer this for pretty much everybody. even with the Achilles tendinosis, non-insertional or insertional tendinosis. And we were able to recreate or reproduce the same results. At a time, if you look at it, like they were just very small number of patients. But if you look at the VAS pain score, operated with 1 year, there's a dramatic reduce, and the FFI was also the final follow-up. So at least, I mean, my about 2 patients I had to had to go for the definitive surgery of FHL transfer because I scratched the indication of the severe tendinosis of this patient. But overall, all of them were happier, and I continued doing this surgery or offering for my patients with Achilles tendinosis now. Now the question comes down to gastric recession or PERC TL. This is very important. This will be published how the PERC TL looks like. You number one, if with the knee flexion, if there is no increase in dorsiflexion, that tells it's coming from Achilles. Second thing, my patients with the diabetes, my patient with the diabetes with the ulcer, forefoot ulcer, my patients uh, with the severe posterior tibial tendon dysfunction, I prefer to do PERC TL over the gastric because I'm able to get better correction and because their pathology is coming not only from gastric but from the TL or Achilles. So ongoing studies, we all constantly, it's very important. You keep on looking at your data that, hey, you are doing the right thing. Because I published 5 years ago doesn't mean that I should continue doing. And we are looking at more of this. These are the patients, like, and we are looking at more of about, this is preliminary results of like 89 patients, or we were able to get the promise score in this paper. And we look at more of the average follow-up was like, it's a pretty good, like, about 17 to 18 months. And we were able to see very good results with the gastric recession, with the plantar fasciitis, or even with the, when we look at the resiliency, they're outstanding with this population. So basically, when we look at the summary, these are the slides prepared by my research fellow, it's basically time from surgery to collection of, let's say the promise score was collected in the first 3 months after surgery or a year down, it did not affect the score because gastric recession exhibit immediate effect on the promise score, or because it's a minimal prolonged recovery with these patients. Patients with equinus contracture, when it was done with them for different pathology, they were not able to, they did not seem to be that happy in comparison to my patient with Achilles tendinosis or plantar fasciitis. And resilience plays a dramatic impact for these patients. So the last slide, sorry, I just went beyond the time. The patient with the gastric recession is a safe and effective treatment for plantar fasciitis, Achilles tendinosis, some delayed presentation of fractures, forefoot pathologies in patients with isolated gastric contracture were failed conservative management. Transient neuritis or transient weakness, loss of muscle contour, specifically for the older population, should be warranted. And I believe it's a good surgical procedure with the least morbidity and without long-term consequences. Thank you.
Yeah.
Yeah, sir. Aditya, sir. No. I personally have seen you doing these cases, gastric release for all those cases. One simple question. Do you find, is there any racial difference in this? You mean Indian population has less kind of contracture than the Western population? So do you think it is useful in India?
In this way, I mean, I don't see many Indian patients in my practice. Maybe they have high pain tolerance, or being immigrant, we are very high pain tolerance, are more priorities. But like, trying out everything conservative management for 6 months, 9 months, 12 months, couple of years, uh, I'm able to reproduce the results with this. Patient seems to be happier, and
I
I mean,
can put on
I don't know
I can
about the
put on a
Indian,
word
but
on that.
Rajesh can tell more about the Indian
Yeah.
patients, So
I can put in a word on that. The thing is, we are moving away from the Indian toilet, which is
Yes.
a very important part of the Indian culture. So the gastroc tightness never happened, the hamstring tightness never happened when we are using the Indian toilet. But now we are moving towards the Western toilet. And as I can see, a lot of my patients, especially where I practice is in Kerala, we have almost 95% moved on to the Western toilet. And I can see a lot of gastroc tightness. And yes, I have seen, as you guys have seen, I've also seen Dr. Ashish doing gastroc recession, and no, it's his favorite surgery. And I have also done that to a number of my patients. And yes, we are finding a good release. So I think it is the change of our livelihood. In the village, people still use Indian toilet. Gastric recession might not be so much helpful because they are already stressed out. But in urban, most of our patients are equivalent to a Western population.
That's a great question. I've seen even within the United States, I think there is, different folks have different kind of collagen. That's what I feel. If you think of it as a spectrum, so one end you have Ehlers-Danlos syndrome, the collagen and everything, the fabric of the tissues is very lax. Then similarly, on the other end, you probably have folks who have very tight collagen. The structure, the muscle, and everything, they are stiff. They are stiff, stoic, built. I've seen laborers, they hold their hands, they're holding like, not like a doll. You see what I mean? So I think at one end, you will have some patients who are very flexible. And those kind of patients don't turn up in your clinic in the first place. I think those folks who have a built-in stiffness in their tissues, they come to your place because they have gastric tightness, and that's why you have either plantar fasciitis or Achilles tendonitis. So I think they self-select to us based on, maybe Rajesh has said, it could be that some folks are getting tighter because they're not sitting on the floor, or in Indian way, stretching their muscles. But some are more prone to tightness than others. And I've seen that in Texas. If you ask folks in some parts of the country in USA, they strongly believe gastrocnemius recession is not necessary. Ashish, you might remember Keith Wapner strongly believes that anybody can stretch their Achilles tendon. I do not think so. There are some people who, no matter what, Ashish showed a great video of the ladies stretching. Pigeon toeing is very important because if they are pointing their toes outside, it actually makes things worse. Very important to realize, teach the patient you cannot make things worse. You need to turn your toes inside and get the heel at least neutral, if not, into varus, and then do an effective stretch. But no matter what they do, you can use night splint, you can do that stretching. Some people are impossible to stretch their gastrocnemius. And that's where I think recession will work very well. So there are some patient types, I think, whether in India, because or the type of the lifestyle or their collagen structure makes them prone for tightness. That's my take. I think I've seen this enough. So, but I've gone, I'm doing gastrocnemius recession. Every time I do a tarsal tunnel release or Achilles tendon, treatment for Haglund's deformity and so on and so forth, I add a gastrocnemius recession. I not do it through a small incision. I used to do through the endoscope, but all you require is a small incision, really. And you can move the tissues. Soft tissues are very pliable. You can move from side to side, and avoid the sural nerve. You can see that sural nerve very well. By the way, congratulations, Ashish. That's a great demonstration as to what might happen to the sural nerve, whether it's resilient or not. I haven't seen so much sural neuritis in my own practice, but I will be careful to look out for it. But that cadaver study which you did does show that there is a stretch. But now whether it happens acutely, because in cadaver, does it happen in humans? We don't know. I mean, in vivo, we don't know. But if you're seeing some sural neuritis, it could be because some stretch during intraoperative handling of the nerve, maybe, or maybe the stretch which you're showing. We don't know. But congratulations on thinking about that study and doing it.
And
Uh,
again,
can I
and
have a
like,
word?
yeah, please.
Yeah, go on, sir. Go on, sir.
No, what I feel like, not only for plantar fasciitis or Achilles tendinosis, but let's say you are doing the tongue type fracture of the calcaneus, right? And it puts so much pressure on the skin. And number of times you do the beautiful correction, but Achilles is such a deforming force. You add this gastroc acutely, number of times like an irreducible dislocation. I mean, when I do the calcaneus fracture at 3 weeks, I'm not able to bring the pitch. I do the gastroc, add that. Number three, when you're doing the flat foot reconstruction, see when the posterior tibial stop working, okay, and then the most deforming force is Achilles now. So you need to just get rid of this deforming force up to a certain extent. Same thing for the cavo varus. Same thing when you are repairing the tibialis anterior tendon. If you keep the Achilles stronger, what will happen? It will put more stress on the tibialis anterior. So these are the real indications that you add along with that.
Coming to my side, I would definitely back Rajiv Simon sir regarding the tightness, because there is a shift in the gastric tightness in the population. What we see, the younger generation is most of the time they are complaining with that. But my take is I've seen few cases with a midfoot arthritis, where when we see radiologically there is an hindfoot equinus is there, and the break happens at the midfoot. So do you always confirm it radiologically before going for the gastric release, or like split second effect I want to talk about?
It's more of the clinical diagnosis. You do the silver score test and you check it out. Number of times, like, simple example, not the midfoot arthritis, but my 45-year-old male comes with the Achilles rupture. So, or my patient comes with Achilles tendinosis. I ask the question, did you ever have heel pain in the past? Did you have plantar fasciitis? You've been treated? They say, yeah. How do you know this? So that automatically tells, hey, this might be the precursor, the tightness. And that now continues, like, leading more stress and more of the worsening and increased stress and made tendinosis. But number of times my patient with midfoot arthritis, if they're equinus contracture, silver skull positive, I add the gastroc along with that.
Right. So, coming to the forefoot part, if there is any case of a metatarsalgia where we need to do some weeds to correct it, there also you will be adding the gastric recession.
Yes, I do. I do for a number of patient who has like, that you see severe callus pattern, but they are not rheumatological patient. Uh, they have the silver skull positive. I do that for, but for the non-healing ulcers, specifically in diabetic patients, I'm in the beginning of my practice, I used to do gastroc for them, but I was not able to reproduce the results. So for all of those patients, diabetic, ulcers and stuff, I'm able to reproduce or getting better results with the PERC TAL versus the gastric.
So,
Sir,
yeah.
so
Only thing, sorry.
sir, one question regarding the silver skull. So, do you really put the heel in varus or neutral for testing? I mean, for exact reassessment assessment?
Very important to look
Tarsal joint,
lot of
right?
joint.
So
Basically, if you leave it in valgus, you see it's Achilles tendon is taking a shortcut. You have to at least bring it in neutral, and then test the length. You see. So, and you'll be surprised. So many patients have that gastrocnemius, contract and forefoot overloading, hindfoot, tendinitis, plantar fasciitis. Most of them are related to that. And even some people believe that plexahallucis, I mean the arthritis in the big toe, at the base of the big toe, tight FHL, tight gastrocnemius are contributory to those things. And it works very well in diabetes. The only thing one has to be careful about is overdoing it. If you do overdo it, over lengthen it, then you have a problem. You have a calcaneus deformity with the heel ulcer, risk of heel ulcer.
So the final question in short, sir. What do you feel? The gastrocnemius is really the friend or a foe for the foot and ankle?
Recession is friend.
Yes.
We have neglected that friend for a long time.
Yeah.
It will. We can take it as a friend.
Yes.
I think
But
if you follow Dr. Ashish, then the gastroc is a best friend, not a friend.
They always make a fun of me. Like, if the patient comes with cardiomyopathy, Shah will offer the gastric recession, and that patient will feel better.
Might do. Who knows? There might be a link there. You might be able to walk more. Therefore,
That's true.
right. So we'll be proceeding to the next talk by Dr. Rajesh Simon, sir, on pylon fracture.
So good morning, everybody. My talk is on pylon fractures. And I would like to thank all the organizers, especially Dr. Kamlakar, for having invited me in this talk. So we all know that pylon fracture is a soft tissue injury with a concomitant fracture. So you got to understand the relevant anatomy here. You have a very thin soft tissue area with a dense trabeculated bone. And when you give an axial load, it shatters like crazy. So you got to understand that here it is the soft tissue which is of paramount importance when you're talking about the pylon fractures. The fracture fixation, the gold standards of AO has still stood the test of the time. There is no change on that, but the idea is to have the soft tissue management, the soft tissue envelope has to be good, and that is the key of the success. Sirkin and Sanders had presented this in 1999 that the delay of surgery in pylon should be ideally be done from 7 to 14 days time. And that is still the stands today. The same thing, the current techniques also emphasize the soft tissue injury. So when you get a pylon fracture, the first thing is you got to span the fracture fragments and then go for scan and plan what to do. So when you plan a scan, you should know that it should be a spanning external fixator in both the columns, medial side and the lateral side. Your talus should be centered in both AP and lateral view, and you cannot have the disparity in medial or lateral subluxation. Once you span, the advantage is it decreases the pressure on the soft tissue. Your ORI becomes easier. Your planning with CT is much more easier because you've got a destruction view and everything falls in place. Even if your plastic friends wants to put a flap, you can do it with an external fixator and delay the surgery. But when to do the definitive surgery? You should not do it when it is red hot, because if it is red hot, you are in trouble. So you got to wait for the green signal of the wrinkle sign. And once the wrinkling is happening there around the ankle, and then you can go ahead and fix the fracture. So you always respect the soft tissue, and you should identify which fracture, where is the soft tissue more problematic, and it is not same in all the pylon fracture. CT scan, once you've spanned the fracture, you got to do the CT scan, because this is a classical paper of Tornetta. 82% of additional information is got when you do a scan after your spanning. So see, for example, here in this particular place, we have not scanned here, but if you look at it in more zoomed picture, you find, okay, there is a fracture fibula, the medial malleolus vertical shear fracture. Not so bad. But when you took a CT scan, you can understand the amount of injury now The whole area is kind of fractured here. And the most surprising fact was the intra-articular fragmentation. And that is what is very important when you take a CT scan. So you understand the articular fracture patterns, which is very important in the pylon fractures. So plan your fracture fragment fixation by the condition of your soft tissue, and then, yeah, more importantly, about what approach and what implant with the fracture geometry. So you got to understand where you want to keep your plates and where you want to keep your metals work. So you got to understand the fracture geometry. So when you look at the fibula, if the fibula is towards medial side and the tensile side is broken, the medial side is shattered, you got to build up the medial side. When the fibula is in the lateral side, that means that the compressor side is shattered, is injured more. So you got to open up from the lateral side and build up the lateral side. At times you might find the fibula is intact, and you might think, okay, it's not so bad. But here you got to look at the articular surface. So that you have to be looking at it every angle. You should know the fracture geometry, understand the fracture geometry for proper bony management. The fibula is fractured at about 70 to 80% time. And as I said, the varus or valgus or intact guides you how to fix the tibia. But should we fix the fibula first? Yes, if you have not comminuted fracture and you can anatomically restore it without much of a problem. But if it is comminuted, it cannot be anatomically restored, or it compromises your tibial then it is better not to do the ORIF of fibula. So there are a lot of people who do fibula fixation first, put an X-fix medially and leave it. I probably would now say not to do that, because it hampers on your definitive management. If you have really planned that your approaches will not be affected with the fibula plating, that's fine. But otherwise, if in doubt, leave the fibula alone and fix it when you're doing a definitive fixation. Surgical approaches, you have so many approaches: anterior, anteromedial, anterolateral, lateral, and posterolateral. Which surgical approach? Anything which is good for that particular fracture fragment. And a recent paper saying that surgical approach actually does not appear to have a significant risk factor. Select the approach for the fracture geometry. So anteromedial approach, for the medial side, you have to preserve the peritoneum, and you can do that for the medial side. And anterolateral, you can go from lateral from the parallel to the fourth metatarsal first, or you can do a small incision for a chipot fracture. So, and then the lateral, you can open up from the fibula towards the lateral aspect of the tibia. So whatever it is, you got to do as per the fracture geometry, and use a distractor for getting this articular reduction. You got to have a reduction strategy starting from the posterolateral to the anterolateral, and then fix up with multiple K-wires, use proper screws at times, because use of lax screw when treated with MIPO speeds the fracture geometry, because it's kind of got everything in place anatomically. And then you can add on with a neutralization, small plates, especially when your posterior segment is involved. Use a small posterolateral or posteromedial plates and buttress it. If you have a large spiked metaphyseal fragment, it's better to open up that area, get that metaphysis proper, treat it, put a cerclage or put a screw and hold it in, and get the length back once when you put the metaphyseal spike back. So in varus injuries, you can put a medial plate. In a valgus injuries, you can put a lateral plate. This is not a dictum. It is a kind of guideline that helps you to plan out where to put your implant. So here, let's see this for example. So here the varus side is failed. You have the varus tilt. the medial side is completely shattered. So you put a small plate for the lateral malleolus and build up the medial side. And you can use a small incision for the Tillott-Chapo fracture, and you can fix it with the lag screws there. So here is an anterior fragment. The anterior fracture line exits medial to the medial shoulder. And so anteromedial approach is important. Again, build up with a distraction, with the build up the medial side, small K wires, hold the metaphyseal fragments, put screws, and then buttress with MIPO technique. And you don't have to open up too much. So which approach here in this area? You look again, this is a anteromedial, anterolateral dual. If we had time, I would have gone for a question here. So here you see it is the anterolateral side which has been shattered. It's a valgus type of injury. So posterolateral plating for fibula, anterolateral plating for tibia, and a small MIPO plate medially to hold the medial malleolus. So you got to have a dual approach, many a times triple approach. So learn to see the fracture geometry, and then you decide how to go about it. When it's a posterior fragment, it is always nice to have put a couple of screws, build on it, and then do a biplanar or a MIPO fracture, a MIPO fixation. You don't have to open up big incisions. Here you can see a biplanar fixation with MIPO technique, and all these plates and screws is there with the MIPO technique, and patient heals on well. If you don't understand the fracture geometry, then this is what the problem is. Here, a valgus type of injury, very classical valgus type of injury. Here, an external fixator was done wonderful. The surgeon did it perfectly well, waited for the fibula, the wrinkle sign to have, but then you see this fibula. The fibula is overriding. It had to come down to get the length back. The moment it lengths back, the talus would have been corrected underneath the tibia, would have got the length. So a fibular plate and then an anterolateral plate would have been ideal, or probably a MIPO medially here would have been helpful. But the surgeon did it in medial side, and the fracture goes on to unite in this way. But the fibula is not united, and you can already see the arthritic changes in the ankle. So this is where your problem is. You have to understand the fracture geometry. In case of open fractures, do not get intimidated by the wounds. You got to go to that same dictum, span the fixation, span it with an external fixation, do a good debridement, and you see this one, such a bad looking, and once you have put it in external fixation, not so bad. You don't even need a plastic surgeon here, and you wait for the wrinkles with the swelling to subside, and then fix it as per the fracture geometry, and you can get a very good results. So at the end of my talk, I would like to have some take-home messages. Respect the soft tissue injury. You've got to look at the soft tissues, understand the fracture geometry, and then you can go as per which implants, which approach, and you can and you will avoid complications if you do meticulously well. Thank you very much for your patient listening.
I think the talk is open for the discussion now.
That's a great talk, Rajesh, and I have definitely seen your work, and you also see how most commonly neglected this fracture is, like minimal fixation, lack of doing the CT scan because patient could not afford, I mean, this is not just an orthopedic bones injury, it's a big soft tissue injury, bone injury. Number of times, that people just put the anterior plate where the fracture is also extending medially. You have to buttress with the medial plate on top of that. But specifically, most important part is the posterior malleolus, the posterior pilon variety of the posterior malleolus fracture, you treated this aggressively. That's also very important. And I agree with your comment of like, that earlier 4 years or 5 years ago, the paper was published, hey, you should fix the fibula, put the external fixator. But I would definitely add, if you are not the surgeon who is going to fix the pilon, don't fix the fibula, because you know what you're going to do in the future. No, that's great.
Great talk, Rajesh. I want to emphasize one thing you said. The fracture has a memory. So basically, when the fracture goes into a varus, that means it has stripped the soft tissues all along, up and down on the medial aspect. So you have to buttress it on the medial side. You may leave the fixation on the lateral side very flimsy or weak. You do not want, if you strengthen the lateral side, it can drift into varus. So same thing happens with the anterior pilon. So if you do not put a plate anteriorly, it will go into a recurvatum deformity, procurvatum deformity. So it's important to remember the pathology, the pathogenesis or the drift of the fracture, and then and try to buttress it. And Ashish also mentioned sometimes you have anterior and a posterior compression. So you need to bring the posterior malleus down and then build up the rest of the stuff. Again, like, 10, 15 years, 20 years ago, I think there was a dogmatic approach of fixing the fibula first, but when it's a really comminuted fibula, you really don't have a sense as to the rotation, as a length, or even because fibula is not a straight pipe. You see, it just got a little nice curvature. So if you're slapping a strong, stainless steel plate on it, it takes the form of the plate, which may not be the anatomical form of the fibula. The curvature, the subtle, anterior or posterior. If it's been the middle, you might, procurvatum, or you might fix the fibula into a posterior angle or an anterior angle. There's so many ways you can flaw it. So getting to the fibula fracture that matters, the fracture that matters is the tibial pilon. You can ignore the fibula fracture altogether. Getting the metaphysis anatomically restored and then aligning the metaphysis to the tibial shaft is the main aim, and should be the main aim, obviously protecting the soft tissues.
In this important part, especially when we talk about Indian part, we always say about the financial program. So I think when there are things which you should learn, you're doing more harm than good if you're fixing a pylon without CT scan. So I think CT scan is a must. Even if you have a financial burden on the patient, I think you can talk to the CT scan people, get the maximum reduction. Do good, don't do harm. And secondly, as Dr. Vinod was saying about the fibula, I think pylon fracture is more for a younger individual. We're not talking about a geriatric person having a pylon fracture. So using the anatomical, the craze now is you have these anatomical locking plates which are coming in the market. I would probably never use a locking plate in a pylon fracture, because you're possibly changing the anatomy with the plate. So use a 1/3 tubular plate, which goes more anatomic, or try to be as anatomic as possible if you're trying to do other plates. But respecting the anatomy, respecting the soft tissue, and knowing the fracture geometry is the key of, anybody can fix it, but how to fix it is by knowing the basics.
I have a small query. The basic thing is, in any pylon fracture, there is a metaphyseal and diaphyseal dissociation also associated with that. So the key exists on the ankle is to get the correct alignment. Do you have any tips intraoperatively where we have a lot of comminution, where we cannot get a fragment on fragment to get the alignment correct? So
that is what the basic, the fibula fracture initially, as Dr. Vinod was saying, the fracture has got a memory. So the basic fracture, and the easiest place to look at is the fibula. The fibula is valgus or varus. So it shows you where the tensile side or the compressile side is broken and shattered. So If the fibula is not shattered, then fibula definitely helps you out in getting an alignment, a length, and to some extent rotation. But if the fibula is shattered, then you got to look at it, that means the lateral side, the compressor side, then the medial side is the place where you have to look at it. Very rarely you have both sides completely comminuted, completely shattered. And that is where I would probably, if in doubt, I would probably take in the opposite side X-ray to keep that as a template, and then use it to build up my fracture area.
Probably it would be a long leg X-ray.
Yeah, the opposite side X-ray, opposite limb X-ray would be very helpful, because many a times the talocrural angle is different in different patients. Your fibular length is different in different patients. So the opposite side always helps in getting the template done if it is grossly, if the fibula is grossly comminuted, so that you do not know which length or how much length of the fibula should be there.
Yeah, sir, one question. Most of these trauma surgeons which recently have seen is there any workhorse approach? Like, see, I know that a lot of approaches, anteromedial, anterolateral, but so people say that workhorse approach is anterolateral and posterior, most of your fractures get fixed and minimal wound issues. But I have seen all the approaches, I've done all approaches, but I've burnt my hands with every approach. But what I think is the least lesions, least wound complications I have was anterolateral or direct lateral. Probably plate would be covered or
See,
my dissection.
the medial approach is very simple, because you just have to open up. But why most of us have burnt fingers in the medial approaches? Because it's a subcutaneous plane, and why we emphasize on anteromedial approaches, because you push the plate medially, so your incision is not over the plate. Your incision is away from the plate. So that is why one tip: you should not use the direct medial approach, because you're going to have the plate just beneath your incision, and you're going to have a problem. Anterolateral is safer zone, because you get the soft tissue problem is lesser compared to the medial thing. But as I said, the fracture geometry should be the one which guides you which approach. Don't be biased on one particular approach when it comes to pylon fracture. It has to be the fracture geometry which dictates you where to go. At times, I showed you the last one of my the fibula was there was an anterolateral so the fibula was fixed in the posterolateral way, and the tibia on with an anterolateral If I would have plated the fibula directly first in a lateral approach, then I would have had a problem in an anterolateral, because the skin bridge would have been very less. So that is why the geometry of fracture will dictate. Plan it out with a CT scan, and don't be fixed with one. Will have complications. Even with the expert hands, all of us have got complications. So that's part of it. You have to live with it. But then you always have a plastic surgeon also to help you out if you have got a soft tissue problem more than that.
Coming to the approach part, I just want to get the comment on, there is one approach which is being spoken of, like extensile anterior approach, where we'll be able to see all the 4 columns. So what is your take on that? Because with that approach, you will be able to see the posterolateral, anterolateral, and medial column, where you can plate all the 3, even anterior, medial, and lateral.
That's a good point, Kamlakar.
Yeah.
People have, if you have anteromedial and anterolateral incision, and these folks come later on down the line to have a total ankle replacement, so at times there is a problem. And I had scenarios like this where I was lucky, and scenarios where I was not lucky, putting a total ankle in those kind of patients. So you can certainly use incision which you use for total ankle and get a great anatomy in front of the ankle. But the important thing is to respect the flaps. Just like Ashish said, for the, like wherever you are, I think, dissecting under the skin and trying to fillet those soft tissues, it's not going to work. So directly, you need to know between which tendons you need to go. Usually the tibialis anterior tendon and the EHL tendon. I go down that path. And preserving the sheath of the tibialis anterior is very critical. You need to preserve, you need to give as much tissue as possible to the tibialis anterior tendon and move away, but between the EHL and the tibialis anterior. Go down there and open the fracture like a book. You can go to the central depressed fragments and you can push them down. You can bring that anterolateral fragment. You can align the anteromedial fragment all the way up to, because you need to have a long incision. You do not want to work with small incision, then you protract a lot of retraction there. A long incision, not dissecting under the flaps, choosing the path, opening the fracture as a book. Very important, not to devitalize those fragments. So you don't want to, take off the periosteum from the anterolateral fragment or anteromedial fragment. But you can mobilize those fragments after put it in distraction if you need to. If you're going 3 or 4 weeks later, you need to put it in distraction. You can get the gap you need to work to bring those fragments, central fragments down, anterolateral, anteromedial. Then once you have that, you can put those K wires, which Dr. Shaman has shown very beautifully in his presentation, and then shoot cannulated screws first to kind of build a building block there, and then you can slap your plates. But yeah, that's a great point. Anterior midline approach, but protecting the sheath of the tibialis anterior is a workhorse. Like Aditya was wanting to know what was the workhorse. That is a great workhorse, approach for most of the pilon fractures, and it sets the stage in case the patients want to have a total ankle later on. You're not, worried about vascularity or flaps.
Yeah, I agree with Vinod. Like it has become more popular among the foot and ankle orthopedic surgeons instead
much
in
experience
comparison
in
to the trauma surgeon. But yeah,
So regarding this gap between the two incisions, that is like 5 to 7 centimeters, which should be around ankle. Does it hold good?
That's a nonsense. That is nonsense. As long as you maintain that not dissecting the flap, you cannot have 7 centimeters. A kid
it's
comes,
not possible.
whole leg circumference is 7 centimeters. Where the hell will you put another incision?
Yeah,
No, that's nonsense. That was AO old teaching, just like the fibular first approach they pushed around. That has been debunked.
And how close do you put the incision, sir? How close
You
can you
can
put?
put as close as you. I mean, obviously, not within a millimeter or
No,
so.
like
But
if you have to go medially and then posterally, you have a Chaput's fragment.
yeah, I mean, if you make
You
a
can-
small incision for the sharper, you can put it. You can put. I mean, if you have a medial incision, no problem at all. And, again, do not dissect under the skin. You will not have any problem. You will not have a problem. I do it all the time. If I have an anteromedial incision for a, very segmented varus collapsed fragment, I put a plate there and a sharpened fragment. You make a small incision there, no problem. But again, do not dissect under the
So, are we moving more towards mini fragment fixation?
Sorry, can you repeat that?
Are we moving more towards mini fragment fixation, like buttressing in small plates and all, in tibial pilons?
I mean, fragment specific fixation, tackling
um,
each.
Hybrid.
not
So yeah, external fixator with internal fixation. Are you talking about external and internal fixation? I think you need to have a robust fixation enough to resist the muscle. You forget there are strong muscles and tendons spanning the ankle. There is Achilles tendon, which is very powerful, and the pain starts a response of all these muscles. You contract all the time. Even if you put them in a cast, the muscles keep acting. So whatever you put implant wise, it has to offset that continuous forces the fragments are facing. Ankle joint faces the fragment. But when the skeleton is broken, then all these muscles are trying to contract. That's why if you go in and try to stretch this out, it's a struggle. It is a struggle. Within a week, that muscles and tendons contract so much that it's a tremendous job to distract any fragments. So you have to
Yep,
think any fixation, any implants you put in should be able to withstand and resist those constant forces that are going to happen across the fracture or across the joints.
Yep, you need a long lever arm, with the fixation. I mean, if you want to do minimal invasive, you need to protect with the external fixator for longer, right? Otherwise,
Yeah.
just do this fixation and you stuck the bigger, longer plates with a longer lever arm.
Unless you see, so if the is this minimally displaced fracture, that means the soft tissue envelope is still intact, and you can get away with percutaneous tissue, fixation. Actually, we published a series of percutaneous fixation in pilon, but we were very selective. I mean, you can't do that for type 3 with severe soft tissue disruption. It's highly unstable. So, just a tiny bit of 2 millimeter, more than 2 millimeter depression, but, it hasn't stripped off the soft tissues, then you can reduce them. And then soft tissues provide enough stability there. So again, either whatever need be, the stability is critical. Every case is different.
Sorry, definitive ring fixation for pilons. Definitive ring fixators.
So definitive ring fixator. Again, once you get, I mean, obviously there are reasons for that. Obviously, there's some soft tissue problems or vascularity issues. You can percutaneously reduce those fragments, and then certainly put a ring fixator. And you can use those olive wires to bring the fragments and hold the fragments together. But again, you should not compromise if it is possible. If there is a contraindication for internal fixation, so yes. It may not be as accurate if you're not that skilled in putting those olive wires in appropriate location and direction. But certainly those folks who are skilled in putting laser-off frames, they can actually reduce it and accurately get the metaphysis built up and then get the alignment as well. But just throwing the external fixator on top of it, it does not, get good results as long as if you do not get the metaphysis built in nicely. Restoring anatomy, restoring the joint surface, restoring the alignment, you cannot compromise on those, whether you're using internal fixation or external fixation.
If there are any no questions, can we go ahead, sir?
Okay, yeah. I think we are running a little late, I suppose.
Yeah, yes. Can you go to the next talk?
Next talk is
Dr. Gopi Krishna, factors modifying the outcome of surgical management in TALUS.
Good evening, everyone. Today, I'm going to talk about factors modifying the outcome in surgical management of fractures and dislocations of talus. Talus fractures are uncommon and often accompanied by other injuries, and displaced fractures of the talar neck and body are best treated urgently to safeguard the precarious blood supply. Reduction of the dislocated joints are critical to maintain vascularity to the talar bone where possible and to reduce tension on the soft tissues and neurovascular structures around the foot and ankle to safeguard the outcome function of the foot and ankle. Major fundamental rule is to safeguard blood supply and to prevent AVN and thereby better functional outcome of the foot and ankle. Aim of my study is to study functional and radiological outcome in surgically treated talus fractures and dislocations. Objectives are emphasis on urgent reduction of the fractures and dislocations, anatomical reduction and good soft tissue handling and coverage, to evaluate radiological outcome and to evaluate post-operative complications. The present retrospective and prospective study includes 20 patients operated at Nizam's Institute of Medical Sciences between January 2017 to October 2019 with a minimum follow-up of 1 year and maximum of 2 years. Open reduction with cancellous screws was done in 12 patients, percutaneous K-wire fixation in 4 patients, and external fixation in 4 patients based upon the skin condition, amount of comminution, and displacement. Skeletally matured individuals, closed and compound traumatic talus fractures, fracture dislocations of talus, and surgically managed fractures are included in the study. Patients were followed up at first month, third month, 6th month, and 1 year minimum. Serial radiographs were used to assess the reduction as well as to analyze any signs of avascular necrosis and also to see the joint incongruity or congruity. My outcome analysis is based upon the determination of ankle hind foot score from AOFAS, Olerud-Moland ankle score, and E. Lindwall et al. For postoperative anatomical reduction. In this study, we assess the factors which influence these above functional outcome scores. Coming to the ankle hind foot score, in my study, there were excellent results in 2 cases, good results in 6 cases, fair enough in 6, and poor in 6. This poor scoring system, poor score pertains to the compound injuries of the talus. Olerud-Moland score is similar. The Olerud-Moland score of my study is similar to the ankle hind foot score study. Lindwall criteria concluded that there is an intraoperative anatomical reduction in 6 cases, near anatomical reduction in 9 cases, and poor anatomical reduction in 5 cases. This poor outcome is pertains to the high amount of comminution in the fracture. Coming to the results, male preponderance is about 16 cases, that is 80% of the cases are males, and age preponderance between 15 to 45 years, that is 17 cases are in between 15 to 45 cases, and majority of the cases being fall from head, that is 60%, and followed by heavy vehicle RTS in 20%. In our study, we compared the skin condition preoperatively and timing of the surgery and the outcome with the avascular necrosis incidence. There were 8 compound cases and 12 closed cases, out of which good skin in 4 cases and poor skin in 6 cases with blebs and deep abrasions. In 8 compound cases, the avascular necrosis rate turned out to be 6, that is 80%. With the patients were with good condition, good skin condition, there was no avascular necrosis in the follow-up. The patients with the poor skin condition preoperatively, 50% of the patients turned out to be avascular necrosis in the follow-up. There were associated dislocations in all the cases and calcaneal fractures in 8, malleolar fractures in 14, and lower limb fractures in 10. Management of the open reduction was done via anteromedial in 5, anterolateral in 7, anterior in 1, and dual approach in 2. Distribution of the talar neck fractures. Most of the fractures pertain to the type 2 Hawkins classification, that is 8 cases, and type 3, 4, and type 4, 2. Reduction was anatomical in 6 cases, that is 30%, near anatomical in 45%, that is 9 cases, and poor in 5 cases. In our study, 9 out of 20 cases, that is 45%, have signs of avascular necrosis in the follow-up, and clinical complaints of pain and inability to walk and undergo daily activities along with gait abnormalities. 9 cases have joint incongruity and restriction of movements signifying arthritic changes. 2 cases are non-union, for which was managed by below knee cast immobilization for 6 weeks. Coming to the post-operative complications, early wound infections were seen in 2 cases, avascular necrosis in 9, post-traumatic osteoarthritis in 16, and malunion in 10. The fracture type, that is neck or body, significantly influenced the malunion rate. That is, varus malunion is found in 60% of the cases of the talar neck fractures, that is 9 out of 14 cases of the talar neck fractures, and 25 cases, that is 1 out of 4 cases of the talar body fractures, that is significant. Coming to the cases, this is a 32-year-old male, fall from 15 feet height, sustained a closed talus dislocation and fracture along with medial malleolus fracture. This was fixed with K-wires because of the poor skin condition. This is the 3 months follow-up. This is the 1 year follow-up. You can see the decreased joint space here, tibiotalar. This is the 1 year follow-up. The patient is comfortably walking with a cane support, and there is a significant reduction in the dorsiflexion and plantar flexion of the ankle. This is a 23-year-old male, fall from tractor, which is on fall from tractor, and sustained a talar neck fracture with medial malleolus fracture. This is the immediate post-operative radiograph fixed with K-wires anteroposteriorly. This is the 6 months follow-up, and this is the 18 months follow-up. There is the joint is normal. This is a 2 years follow-up. The patient has excellent results, and dorsiflexion and plantar flexion of the side is comparable to the normal side. This is the grade 3B compound neck of talus fracture dislocation. We can see an extensive damage. This was fixed with external fixation and a cancellous screws anteroposteriorly. This is a 2 months follow-up. This is a 6 months follow-up and 18 months follow-up. We can see there is no joint space between the tibia and talus. The outcome is very minimal. There is complete loss of dorsiflexion and plantar flexion. Coming to the discussion, Here we compare clinical and radiological data and functional outcome scoring. Here we can see there is a significance of, if surgery is done before 24 hours, the AOFA score is 72, and if surgery is done after 24 hours, the AOFA score reduced to 58%. That is, the p-value is very significant. And initial endormhical reduction also has a significant role for the AOFA score to be good. And poor skin preoperatively also has a significant value for the AOFA score to be high. And radiographic malunion in the follow-up also plays a significant role in the functional outcome of the talus fractures. Management of the talus fractures are complex and they're associated with high complication rates. In displaced fractures, open reduction is the rule. For better prognosis, surgery is in the first 24 hours after injury is the rule. Respect to the soft tissues, good intraoperative anatomical reduction. For poor prognostic factors include compound injuries and severe soft tissue damage and displaced fractures. These are my references. Thank you.
So
It's very good, Gopi Krishna.
yeah.
Yeah, I mean, why do you think you got so much varus malunion in your series? Was it because of the difference or was it combination? Any thoughts about that, Dr. Gopi Krishna? I know it's difficult to follow patients. Congratulate you for what you did, and you're able to do all that with the resources which you have there, able to follow them for a long period. Just I'm curious as to why did you get so many varus deformities? Anything you can do to improve?
Yes, sir. Good morning, sir. Basically, all the fractures which I took were more of a kind of with a poor skin condition and more comminution. So, if at all for varus malalignment, if it shouldn't be there, there has to be a medial side plating to be done. So we couldn't do the plating immediately because the skin condition was poor, and all the fractures, like most of the fractures, were compound fractures. So maybe that was the reason why in the post-operative period I got a varus malalignment and midfoot malalignment.
Another question was, how did you assess the varus malalignment? I saw that X-rays were not weight-bearing. How do you, I mean, are you able to have those kind of weight-bearing X-rays? Does your facility provides that thing?
Actually, I couldn't put that in the my PowerPoint presentation, sir. Most of the cases, I took the weight-bearing standing X-rays of the hind foot, and I measured the alignment of the foot, that is the talus and calcaneum, with the talus, with the tibia.
Okay.
So we'll go with the next talk.
Yeah, so a few things like, I know you guys see a lot of pedestrian trauma, a lot of tailor dislocations and stuff, but go a few things just to keep an eye or keeping in your mind. Like, let's say if the skin condition not permissible for putting the plate medially, you can put small jazz fixator that you guys have available, to maintain the length, right? So that can be done. That's very important. Yeah. Number two, uh, the K-wire is a definitive fixation. It's a challenge to maintain the reduction, right? So you should convert into more of like, cannulated screws in the second stage or some definitive fixation. I mean, that can be much better. I know in Indian population, arthritis or AVN, even one of the X-ray looks AVN, but patient has excellent range of motion. It's more tolerated than the Western population, but at the same time, like, you need to keep an eye on, like, okay, K-wire cannot be used as a definitive fixation, or like, in the scenario, if you can add adjoint fixation, that can be very helpful.
Yes, sir. Sure, sir. I'll
You
draw
don't
the
have to have a plane. You can use a fully threaded cannulated screws to keep them strand out. You see. So you can use some techniques to, keep the length of the medial aspect of the tailor and the various deformities.
So can we proceed to the next talk by Dr. Raju Shah on the neglected talus?
Neglected fracture dislocation talus or this kind of implant failures are very common, and that is the question of the day. Can you really retain motion in a complex and failed talus fractures? In these cases of problems like subtalar arthritis, ankle arthritis, arthritis of both the joints, avascular necrosis, infection, and bone loss. And solutions we have is either TTC or tibiocalcaneal fusion with the nail or with the plate or with the Elizaro. But these all solutions give stability at the cost of mobility. Can we really replace talus and retain the motion? There could be two ways we can do it. We could do partial replacement of the talus or we could do total replacement of the talus. This was a 23 years old male who was treated for crush injury of the foot with a debridement and referred to us at the end of 3 weeks. And the CT scan showed severely comminuted medial side of the body of the talus with a fracture of the neck of the talus. I went in and did the surgery number 2, where all dead bone pieces of the medial side talus were removed. K-wire were fixed for the fibula as well as transfixation of the ankle. Cement spacer with antibiotics was put in and WAC was applied for 3 consecutive times. Skin grafting was done after 3 WACs and extra fixator was continued. It was at the end of 8 weeks that wounds healed and fixator was off and the definitive procedure was on. The question was the 55% of the lost medial talar body to be replaced with what? And we thought to replace it with allograft talus. Allograft talus replacement was done where with the same approach, the spacer was removed and this is how the medial sided picture all looked like. And then allograft talus of the actual size was cut and then it was fixed at the level of the body with the 2 screws, and a body with the neck was fixed with 1 screw and the gap was filled with the cancellous bone grafts. And this is how it went on to unite and patient went on to go back to the normal activities. But the issues of allograft itself, issues of the matching of the size, slow consolidation and compromise at one joint level is the problem. So the best thing by all means would be total replacement of the talus. If we go back to the literature, Japanese professors, they came out with talar body processes first time in 1974. And then he showed 94% good results at the end of 5 to 15 years. The first generation, second generation talar body implants came into war till 2006. But these also showed around 85% good results at the end of 10 to 36 years. And literature concluded that that's a good option where 88% of the survival rate is seen at the end of 45 years with the mean sagittal ankle range of motion to be 25 degrees. Customized talar body implants came into existence into 2005 and they also showed good end result. We use 3D printed technology for customized total talus replacement, which we used already we used to use it for a talar AVN. So customization is a 6-step process. We collect the data from the opposite side, we get a CT scan of the opposite side, we do the segmentation with the software, 3D reconstruction, CAD imaging is done, adjustment is created, turnover of that image, and simulation with formation of the implant is done. Look at this case of male of 39 years who had a compound injury of the right ankle with a lost talus. And after debridement, the defect was breached with the antibiotic cement spacer and external fixator was applied. It was 3 days down the line that the relatives brought talus from the roadside and they wanted us to implant it back. We thought of something different. We got CT scan of this extruded talus and a 3D printable file was created. A trial model of 10% reduction into the size was created with the holes for the anchorage of the talus and holes for the extractor and impactor. And this was the final titanium implant which was available to us. With an anterior approach, we went in, removed the cement spacer and put in this talus implant. This was the X-ray picture at the end of 3 months. And at the end of 3 months, this patient had almost full dorsiflexion and plantarflexion with jog of inversion and eversion, and he went back to his activities. And obviously, this was India's first 3D printed total talus replacement for trauma. Another case of male 26 who had trauma in 2018 with fracture dislocation talus. The reduction was done, fixation was done after 5 days, union was at 3 months, but with the persistent pain and disability, implants were removed. Still, pain and disability persisted. X-ray at the end of 2 years again showed painful restriction, mobility, inability to ambulate. And so we got MRI, and MRI showed avascular necrosis of the talus, total talar body talus replacement was planned, implants, the implant tray with the instrumentation tray, and the trial looked like this. Entry incision, exposure, and excision of the talar neck first, followed by excision of the talar body, followed by trial implant, and trial implant was then replaced with the final implant. This was on table dorsiflexion, plantarflexion, on table inversion, eversion, and on image. This kind of dorsiflexion, plantarflexion, and inversion, eversion movements were seen immediately post-op. This patient at the end of 3 months was mobilized. These are the almost normal dorsiflexion, plantarflexion movements, and he walks normally and has gone back to all his routine activity, including driving a motorbike. Another case where a female of 29 who had a road traffic accident and had a fractured dislocation talus. 3 surgeons, they tried to reduce the dislocation. It was not reduced. Patient was referred to us at the end of 10 weeks for a definitive fixation with the message that we already have reduced your dislocation. When she came to us at 10 weeks, dislocation was not reduced. I tried to reduce the dislocation. When I opened it, I could not reduce the dislocation, and I ended up excising the body of the talus and putting an X-Pix and spacer into the talus like this. It was the then time that we planned that we are going to go ahead with total talus replacement with a deltoid ligament reconstruction. And to balance the implant, we also thought of creating a replacement of anterior talofibular ligament. A plastic model with 2 tunnels for anchor for preparation of the ligaments was created, and the tunnels which were created had a posterior anchorage with the button, anterior anchorage with a biotinodisc screw, and this was the implant which was prepared. An implant had a fiber tape as well as button at the back, and again anterior approach and excision of the whole talus body, even removal of the implantation, implant definite actual implant which was to be put in was taken. The fiber tapes were passed posteriorly and were closed anteriorly with the double fixation with a biotinodis screw. And then this implant was implanted with an anterior approach with two strings, one for reconstruction of the deep deltoid ligament, one for reconstruction of anterior talofibular ligament. This was the anchorage on the medial side. This was the final picture. And this was on table that we could move in dorsiflexion and inversion eversion. And these are the final pictures at the end of 3 months when patient is mobilized. In fact, there are no long-term studies showing the results of 3D printed total talus replacement. In fact, there is no study showing the results of 3D printed total talus replacement. And whatever studies are there, long-term studies, they are focused to talus replacement for AVN, not for the trauma. And so till the time we have such long-term studies available, 3D printed total talus replacement for a short-term result seems an attractive option to retain motion for a difficult and complex talar fracture. That's all. Thank you very much for giving me this opportunity. Thank you.
Sir, any comments on this? Ashish sir, Panchbabu sir.
Yeah, obviously, this is something new, and people are trying to see what else can we do if talus is not totally not salvageable. I think we have to be careful in patients who are laborers, who really want a secure single operation for their life and they cannot come back again and again. TTC fusion will hold them for many years and serve them very well for their physically strenuous function. So, like Dr. Rajiv already mentioned, he doesn't know how long. There are some patients who might survive for a second operation, third operation, and you could be innovative and try those things. But I think for the majority, there is a common saying: don't be the first and don't be the last to adapt a new technology. It's a new technology with a lot of unknown factors out there. But I think, for a common person in physically strenuous jobs, TTC serves them very well. They may have 20, 30 years down the line, some arthritis in the joint, but it's very rare for the number of patients we treat them to have arthritis in the osteoporosis joint. Obviously, we are sacrificing flexibility there, and that may be an issue for some patients. But I think it's not completely, it's not very widely accepted total talar replacement as yet. That's my comment.
No, I mean, it can be a good surgery in some hands for some indicated patients, but majority of foot and ankle orthopedic surgeon, even in states or worldwide, they prefer, that patient with a labor job or non-salvageable, they prefer to go with the TTC fusion. But again, in some patient, it can be good. But anytime with the newer technology, we're waiting for time. Like giving simple example, last week I did a surgery on body fracture, which was missed by the treated orthopedic surgeon 3 months ago. And I did the TTC fusion for that patient. So he was just a 43-year-old, but 43-year-old, heavy labor job, no insurance. His priority was getting back to the job and feeding him and feeding his family and having one job, one surgery, not the multiple surgeries, So we are not treating just one problem. We are treating the whole family. We are treating everything together collectively.
One more point, if I may. When we do a TTC nail, it's very important to place the foot posteriorly in relation to the tibia. So what that does, it minimizes the lever arm. Very often, I have patients in my clinic coming for follow-up. When they're walking down the corridor, I ask my resident, I say, do you think he has any abnormality in the legs when he's walking? They cannot identify. Then I say the patient has something in one side, and then they cannot identify which side was used. So I have videos after videos of patients walking normally. Even if you want to give them some footwear to assist them walking better, you can use a rocker sole modification in case there's ground. But if you push the foot back in relationship to the tibia, you get much more normal gait without any limp. And I use that all the time. So if the body is necrotic, you don't have to throw it away. Bring the tibia forwards to the vascular head and neck, and it will unite. The distal part of the tibia will beautifully unite to the head and neck of the talus. And the avascular thing will vascularize because you're opening the tibial plafond and also the calcaneal channels. It will take some time, but it will unite. So TTC can be thrown out of the armamentaria just because you can print a 3D talus. For sure, certain patients are demanding, they want the motion, and Dr. Raju Shah is doing a good job. Very select patients, very skilled surgeons can do that. But for the majority, I don't think that's a solution. For the majority still, until we prove that they can last forever and ever, we still have to bank on TTC right now at this stage.
We'll go with a quick.
Patient, one thing, like in some of the patient, when you have crushed tailor body, and when you try to maintain the length, I mean, I use a fibular strut graft as a nail, and I do the fixation on the side, like, with the plating and with the screw along the side. So basically, I mean, that's what I did for the last case, like, a week ago, where the body was crushed and there was no bone, just to maintain the length. Like, I did the fibular strut graft as a nail, and I put the lateral plating on top of it. So we have published on it fibular strut graft as a nail for certain complex problems in foot and ankle. So that can be another solution.
So we'll quickly go through two cases of complex talus, sir. We need your opinions on that. I think the screen is okay. Right. Yeah. This is a 21 years old female patient who presented with a complaint of pain and difficulty in bearing weight on the right lower limb. History of injury was 6.5 months back due to fall from height and was diagnosed as talar neck fractures, and it was managed with closed reduction and internal fixation with 4.2 cannulated cancellous screw. The index surgery was done in Jan 2017. The calcaneum fracture on the left side was managed conservatively. Now she has an antalgic gait with a swelling present over there and a cavovarus deformity of the foot, and the restriction of the ankle ROM and subtalar ROM were painful. So this is the X-ray. So kindly, what is your comment on that? Where it went wrong? What else could have been done?
This is the only X-ray you have, I suppose, Kamlakar, right?
Yeah, this was what she was presented with.
Yeah, I mean, I don't know the initial stage or the status of the soft tissues or what the difficulty the surgeon had in terms of equipment availability, how far along the patient was after the injury. Obviously, you can see there is no reduction there, no stability, no fixation, and there is subluxation in the posterior facet as well. Obviously, can't really comment on vascularity because there's a double shadow on the lateral extremity in the body fragment, but you can certainly see the head and neck is very vascular. How many weeks is it already from the trauma?
6.5 months.
Oh, 6.5 months. Okay. There's some patients, some surgeons who are still heroic, and then they can reduce this, because what actually happens is the articular surface is reasonably reduced. I mean, well preserved, because they're not usually putting full weight on these things, and you might be surprised that not only the ankle joint but also the subtalar, the posterior facet of the subtalar joint is reasonably well preserved, and people have actually achieved union in these scenarios and then salvaged this scenario. But again, going back to the same things we discussed before, does the patient want one surgery or want to, experiment with fixation, restoration of the talus and the ankle and subtalar joint as a stage 1. And then if it does not work, then come back for a stage 2, wherein we can do a TTC fusion. See, if the patient leans towards, no, I just want to get one surgery, want to get back to my life, I have to earn money, I can't be fooling around with these things. 6 months down the line, TTC nail. So, again, like I told you, this is a classic. Bring the tibia forward, almost over the head and neck, and then we can certainly put the nail through the anterior process of the calcaneus, and also use what Dr. Ashish Saab mentioned. So you can do a fibular osteotomy and bring the fibula as well in the blood supply in the neck, and provide more stability. So, and they will work very well.
We know, I mean, just think about the take-home message like talar neck fractures. Talar neck fractures are more with the arthritis, not AVN. Talar bodies are more with AVN than the arthritis, right? So now we are turning this into a more of little disastrous with the malunion or poor choice of the implant and trying to do percutaneous fixation. There are some, as Vinod mentioned, there is very small literature on medial opening wedge osteotomy through the talar neck, medial opening wedge through the talar neck and doing the fixation. And you can attempt, I mean, doing that can help with the correction or maybe the fracture correction. But if you're not done, or if the patient is more like what the patient is looking for, you just go as a first definitive surgery, like TTC on the first set, or you just do this opening wedge osteotomy, subtalar fusion, and then TTC fusion down the road. It's more of like, what you want or what patient wants or what you feel comfortable with.
So this was the CT of the patient. There is a clear-cut subluxation of the posterior subtalar joint still.
Yep.
The axial section, you see clearly, there is some amount of body is left with the neck part. So it was though it was starting in the neck, it was ending in the body of the talus. So the same thing, whether to wait and watch or reconstruct and fuse was discussed. All the alternative plans were discussed with the patient, telling them that you may need to go for the multiple procedures and everything. They opted for a reconstruction in the last option of fusion. That means on table, if we are not able to reconstruct, we told them we'll go with the fusion. So they were okay with that. So with the dual approach of medial and lateral, the medial malleus osteotomy was done, implant removal, debridement, or if with bone grafting was done. The setbacks, what we found where the bone was very porotic and the controlling the varus was becoming difficult. We were in two minds because of the extensive soft tissue release might cause some damage to the vascular and all those things. It is done in somewhere around 2017, 3 years back. Even my expertise was not to that extent. So this is what I could get in the immediate post-op. So did a tension band with 2 screws and a bone graft over there. And we followed it for 3 months. And this was what was going on. And at 6 months, we had a doubt whether really the head is being there or it is traveling towards AVN. So at 1 year, this is the status. And this is 24 months. So still the fingers are crossed. And this was the moment what the patient has now. With the footwear, she is comfortably walking. No complaint. But when it goes without the footwear, she has a bit of knee hyperextension still because the dorsiflexion is restricted a bit.
Great job, Kamalakar.
Yep.
That's very, very nice. So that's what I said. Sometimes you'll be surprised.
Very
You
good.
pick those things, but again, you have to have that discussion with the patients.
Yeah.
So
I agree.
unless you actually go in there, we don't know whether we are able to reduce those fractures and or not. And you did a great job putting a AP screw and a posterior
Screw.
trying to do whatever you can to bone graft it, get them back in place. Congratulations, very nice.
But the patient comes with a new concern now. That is, she doesn't get a complete dorsiflexion. So now she wants a complete dorsiflexion.
Yeah, I mean, see what's preventing it. So it could be sometimes, I don't think this is just intraoperative. Sometimes there is an anterior osteophyte, or sometimes it could be Achilles tendon. We have to know what exactly is preventing her from, it could be some adhesions. I've seen sometimes you can just manipulate the patient under anesthesia and you can break those adhesions down. But if there's a bony limitation, then you have to do some bony work.
So, my query was, would a distraction orthodesis at the subtalar joint will give me the dorsiflexion needed with a gastric lengthening?
Oh, no, I don't think,
You
if you go back to the latest, they're not weight-bearing x-rays. That's the drawback, you see. So if
Yeah,
you
yeah.
see that the talus first metatarsal angle is not disturbed, then you don't need to do a distraction arthroplasty at the subtalar joint. You see, if the talus is horizontal or more horizontally inclined, that's when you distraction arthrodesis at the subtalar joint. But we don't know. I mean, see, you need to get a lateral weight-bearing radiograph to know what exactly, if there is a bony limitation there, or is there a soft tissue limitation.
and and if
Or
you look at his x-rays, right? And I know patients, I mean, learning from different conferences, teaching in India, patients are tolerating arthritis or avian very well. You'll be amazed if you do MRI after removing hardware, or if you do CT scan in these patients, it might be like a full-blown arthritis and AVN here, you know? If you try to attempt to do anything, I'll be, there's possibility going downhill here, Just tell like, hey, this is a limitation. Just be happy with this.
Yeah, the same thing was counseled. Uh, Coming to the next case, this is a 32-year-old male presented with a complaint of pain in right ankle and deformity and swelling. History of accidental fall in the lift space. This fellow was drunk and he thought that the lift is there and he just walked in. And no history of other fractures or comorbidities. That was the luckiest part. And he had a small punctured wound on the anterolateral aspect of the foot, with the foot completely in varus and plantar flex. This was the way he was presented to us. And an attempt of reduction was done in ER, but it was not possible. So we had to take him early to the theater. So this is the X-ray of it.
Wow.
And possibly this is the CT 3D reconstruction where the body is shattered, neck is fractured, head is dislocated from the talonavicular zone. So now the query was whether to go in and fix it or plan for anything else. Obviously, I'm not Raju Shah sir to go for a total talent. So
Sometimes these radiographs and CT scans look much more horrible than what you do end up finding. Again, if you distract the bones around the talus, try to reduce it, it looks like a bag of bones situation. If it is a bag of bones, then try to assemble the main fragments and if you can get the articular surfaces where they should be, and you might need to have an external fixator in addition to an internal fixation with whatever you can put and or wherever you can put it. Now, I think you get a semblance of anatomy if you can reduce that talonavicular joint. If there is some articular surface there, sometimes you'll be surprised. There will be some.
Yep.
So yeah, I think unless we explore the fracture, we don't know in these scenarios. Really, we don't know. Sometimes you get lucky and you can restore the anatomy at least at the joint surfaces, and then keep either use a bone graft if there's a bone loss, or while you're trying to reduce it, you might lose some bone, but need to add an internal fixation and an external fixator to keep the length. You can certainly go back again later if things don't work out.
what would be the approach?
So this
Anterior.
you
I
def
would go for this anterior midline approach. Let me see the X-rays on the lateral side. Was there body combination? No, body
Yeah,
seems reasonably well. I think
yeah, this is the one.
do an anterior midline
yeah.
approach.
There's a posteromedial combination of the body too.
And you can
Yeah,
add.
I would do dual approach here. See, the main thing, like what Vinod said, number one, maintaining the soft tissue attached to the bony fragments. Number two, using the pin distractors. Using the pin distractor, like, between the tibia and calcaneus, or calcaneus and navicular, and see that opening up and bringing the bigger bony pieces together. If you have the allograft, you put it together. If you don't, still putting the bigger bony pieces together and making the good bony surfaces for the future surgery, right? You recreate. See, just think about it. If it stays like this, and when you want to do reconstruction 6 months down the road, it will be miserable. But right now, if you make it better architecture, it'll be easier to do the fusion in the down the road. So that's very important. Like, an internal and external fixation both. Like, you should go with the both of the fixation, as we not said. But yeah, these are the cases, like, you never win, but at least, like, that for a future reference, like, for future surgery, you do this fixation, keep the bony alignment, maintain the reduction, and pray.
So the
Skilled
plan was
surgeon like Kamlakar may be able to do that.
we planned for a medial malleus osteotomy, but to the surprise, when we opened it, the total medial soft tissue was stripped out of the medial malleus, and it was naked open like this. So we were clueless what to do with the medial
Dual
malleus.
approach.
We went, we went, we went through the lateral. We went through the lateral approach. Lateral approach. Some disturbance. So when we do, yeah. The head of the talus being seen over there. Head of the talus being seen over there, and we tried to reduce it. Surprisingly, there was another fragment of the head on the medial side other than the lateral. So we got the lateral reduction. As Sir told, the lateral column was least comminuted, so we could get end-on reduction on that. So went in and did a dual plating with a column screw over there. And
That
this
is
was the head fragment, and this is the post-op after 3 months.
It looks
fantastic.
beautiful. It looks great.
Absolutely fabulous.
Yep.
Congratulations. It should be in the books somewhere.
I know.
Excellent fixation.
Very nice.
This is
This
great.
doesn't look like fracture at all.
Yeah.
I know.
Are you sure it's the same patient?
Yeah, it's the same patient, sir. There is no bluffing.
But amazing. Very good.
Yep.
I'll send all the patients to you now from USA to Hyderabad, Sunshine Hospitals.
Nothing, sir.
Really good.
What is the
That is
plate you
wonderful.
used, Kamlak?
The lateral plate was the regular matrix 2.7 plate, but the medial is a dental plate, sir. But dental 2.7 striker plate.
Dental plates, titanium dental plates work very well. That's what I use.
Yep.
So we were a bit lucky with and the medial structures were repaired with the anchor over there. And the fingers are crossed still because he didn't cross the break line of 2 years still.
Even if like Dr. Ashish has said, even if it goes necrotic, for example, you got the shape. I mean, it's like the comminuted calcaneus fractures. You see, if you do nothing, then the reconstruction is a problem. But if you restore the anatomy, fusion is much easier later down the line. I mean, they may not require fusion. So yeah, I mean,
And I think Kamlakar, the take-home message is, even though the X-ray and CT looks very bad, and you have done excellent fixation, and we know that it is going to resist or AVN or secondary osteoarthritis later. But even the worst scenario, even the poorly done cases, I mean, like me, poor surgeons like me, that even the patient can go for an avascular necrosis quickly, but the resist for secondary osteoarthritis for quite long time. Even the get secondary osteoarthritis to become patient symptomatic, to become accept for a fusion, it is going to take another few years. So these patients going to enjoy his natural bone for at least quite few years for before fusion, and they will get a reasonable movements. They are very, very happy. So only the ankle and foot, even though anatomy sometimes distorted, the tolerance of our patients are very, very good with the good footwear. So this patient, I think primary fusion should be, you should take extra caution, I mean, to attempt for a primary fusion in any bad talus fracture or calcaneal fracture.
Sundar, did you say poor surgeon like you? You do this through a scope, I know.
I know.
Man. All right.
Yep.
So we'll proceed with the next talk by Dr. Vinod Panchpavi, sir.
Thank you. I'll share my
MIS.
screen, if that's okay.
Yeah. No, ask them to stop.
Okay.
Hey, just a minute, just a minute, sir. Stop him. Sir, if you are going live, or you will be talking on the same talk which is being sent to me.
I will go live. Is that okay? Or you can
Yeah.
use my talk if you already have it. I don't.
No. Either way is fine, sir. If you want to go live, we'll make it up. You can start.
Is this my slides or yours? I mean, did they put up?
I think they have put up, sir.
Okay, then let the talk. Let's see if that works out. Okay, that's fine. It's not working out. Let me do it my way then.
Pardon, sir?
I don't think it's working out like that, right?
Sir, please next. You tell me next. So next slide, sir.
So I can't share my. Okay. Okay. So
sir, you share your screen.
Yeah, I'll share my screen then.
Okay, sir.
Yeah, let me share my screen then.
Yes, sir. Please share your screen, sir.
Okay. All right. Thank you so much. Where is it? Can you all see my screen then? Can you all see my screen?
Yeah, it's visible.
Okay, one moment. Let me just put that in a speaker mode.
नहीं वो बोला कि मैं हम प्ले करेंगे वो प्ले करेंगे वो करेंगे मैं अपनी स्क्रीन शेयर करूंगा तो
I'll play. Yeah. Again, I want to thank the OSS.
हाँ नहीं कोई मैंने कर दिया मैम कर दिया.
Okay, and I want to thank Kalakar and the organizers for this opportunity. So basically, I want to talk about minimally invasive surgery, and you know, my premise is, you know, so if we can certainly do it through a small holes, why make a big hole? Why do a complete exposure when you can actually use keyhole surgery? So that's the thing I want to talk about. Yeah, and also in a historical context, you see this, you know, sex lopresti described as long time ago, right? And then we went to extended lateral approach, and then we are doing sinus tarsi approach. And now I think there are some centers, and you will see why we should be doing this keyhole surgery, you see, because certainly when you expose everything, you will see everything, but you don't want to see them in the post-operative period. You don't want to see the plates and so on and so forth. There's been a lot of studies about the vascular structures and so on and so forth for that extended lateral approach flap. And you want to make sure that incision is not messing up with any blood supply. So, you know, that was based on that thing. And if you do use this ELA, and some people can get away with it if you respect the soft tissues and don't make any flaps on the skin. But you see, for you to use that, you have to wait until the swelling goes away and the wrinkles appear. And even then, the wound complications can be about 5 to 25%. This happens even in skilled hands. And you know, you can put those plates which are less stable than screws and nails. You know, the biomechanical studies have shown that. And if you do a arthrodesis after putting a plate, you need to remove that plate. And to remove the plate, you need a longitudinal approach. So what the minimally invasive surgery requires planning, though. I mean, it really requires planning and really requires a skill. There is a learning curve involved. Like I said before, it's not a new concept. Essex leprosity and Bowler and all these folks were trying to do this, you know, way before they figured out what else to do. You know, with approaches, with the open approach, a variety of techniques they used, you know, like Bowler's traction, heel traction, and so on and so forth to get those pieces lined up. You know, now over the years, people have utilized 2-point distractors, 3-point distractors again to mobilize these fragments. Early on, after the injury, you can do this much easier. After a few weeks, it becomes very difficult. I myself had this distractor put in as ST fragment or K-wire and ST substentricular fragment, and
and a tuberosity fragment, you can actually distract and get that nice reduction on the medial wall. You can see the ST fragment. So you can get that tuberosity out of varus through minimally invasive techniques. Positioning is extremely important if you really want to do this percutaneously. You need to have that extremity laid out in such a way that you can see axial view, bowler's view. If you have O arm, you can use it. But you need to be able to see in two planes and very critically the Harris view and the lateral view. And this is, and fixation can be anything. You know, you can use a nail as Raman described, or you can use screws, K-wires, or even a sinus star plate. You can make a small incision and then slip this plate. I tend to use a bunch of screws. I know there are a lot of screws there, but you know, as soon as you build in this ST fragment, which again, getting the joint fragment aligned is critical. Once you get the joint fragment aligned, then you're worrying about the body. You need to get that body out of the varus, and then you need to put this screw strategically in places where you find the most cancellous or most dense bone in the calcaneus. As you will see, there again, you know, basically what you're trying to do is raft that joint fragment. So you're putting these screws in an axial way, not only to maintain the length of the calcaneus, but also to raft the joint reconstructed fragment. Like I said, you need to have knowledge as to where the densest part of the calcaneus is. You can see there are portions of the calcaneus where there's no bone. So if you put the end of the screw there, it's not going to have a better purchase. So you need to know where exactly the densest part of the body and the tail and the anterior process and the ST fragment and the tuberosity fragment and so on and so forth. Tongue tie fracture. If you want to start off with this, I suggest you use the tongue tie fracture to get in there and try to mobilize that. And it's easy to do so. Again, distraction is the key. There are a variety of things you can use. There are these clamps, we certainly use. Again, positioning is critical. You need to be able to see and manipulate this both medially and laterally. That's why you need to have the leg free to be able to put a medial clamp and a lateral clamp. You can see the power sometimes can bend the wire so much to bring the tuberosity fragment out of varus, especially if the fracture has been there sitting out for a week to 2 weeks or 3 weeks. The later you get from the injury, the worse it is to mobilize this fragment. So you can certainly use joystick things to get in there and move these fragments. People have described a variety of approaches like this, but beauty is you can get away with a small incision. Beauty is that you can get in there when even when there is a lot of swelling. You don't have to wait for those wrinkle signs. And studies have come out now, percutaneous reduction as effective, at least, or certainly not inferior than the open method. And there are the series, case series, and also what you may call a comparative series. Let me see, go back to see. So extensile approach versus a small incision. You can see the advantages of the small incision. Certainly, like I said, early intervention is possible. There is minimal soft tissue injury because you're not stripping out the periosteum from the lateral wall and so on and so forth. You can certainly add a sinus tarsi approach. If you cannot really mobilize those fragments, you can, and I did that in a couple of cases where you can just make a small incision. If it's not getting in there where you really need to put that out, the joint depressed tuberosity fragment, because it's rotated 90 degrees, you need to derotate it. It's sometimes difficult. You can, no matter, just make a small incision and get that out. I think the most of the work is done by the distractions. You need to really have a good hold of the tuberosity fragment. You need to jack it out of the varus and bring the length out, you see. So certainly there is a learning curve involved. You can certainly fix this within a few days, and radiation is the issue because when you're starting out, you're moving the C-arm, you need to have a good radiographer to listen to you, and this way, that way, if you have a laser pointer, it makes it easier, and it can be time consuming. But certainly, if when you can, I would suggest, avoid that long. This is my cases actually. Certainly, I would favor minimally invasive. When I can do it through a small hole, I am doing this through a small hole. Thank you for grateful for this opportunity. Thank you for the opportunity. Questions or comments? Thank you.
Great talk. Like I mean, as you mentioned, I also moved to completely minimal invasive for the last 4 to 5 years. Do you agree with that part? Like, that, hey, with the minimal invasive, the screw fixations are reasonable enough. You don't need to put a plate and,
Yeah,
with the rafting technique. And the
rafting
second
technique.
thing is the
I, I
wrinkle
see.
test is, yes.
I used to see collapse, when I used to do this ELA with a plate, I used to see
Uh-huh.
collapse of the body, you see. Now I'm not seeing that. Again, like I said, you need to start off from the posterior aspect of the tuberosity and go into the anterior process. And then I put a bunch of screws. That particular patient, which I showed, had fewer screws. I put even more screws sometimes, all going axially. So basically, they're fully threaded screws. They're maintaining the length. They're maintaining, preventing that joint collapse. And I think it works because it not only prevents it from going into varus, but also the collapses. So I don't mind putting a bunch of screws there. The more screws, the merrier. So, but again, getting the reduction is most critical. First of all, the joint reduction, and then the anatomy of the body, the varus, and then the length of and then the height. Once you get that, you see, no matter, I mean, if you really love putting a plate, you can, like I said, you can also slip in a ST fragment plate, but I don't think it's necessary really. I think the ST, from the joint depressed fragment into the ST sustentacular tali fragment, if you put 2 or 3 good screws, again, the eyeballing is critical. X-rays are critical. It is, I think I would start, somebody listening there just want to go straight to percutaneous tissues. I don't agree with that. I think you need to really learn the anatomy. You need to know the ELA. You need extended lateral approach. You need to see those fragments. You need to see how the tuberosity fragment rotates, how it's split off from the ST fragment. You need to really understand those things before you jump into the percutaneous technique, I think, so skilled surgeons like in these panels can easily do that, having the background knowledge, having done through all sorts of things. Like obviously, I started with ELA and then moved on to sinus side and then to percutaneous. But if you look at the history, they were trying to do that a long time ago. It's like history repeats itself. Like an interesting phenomena there happening.
I have a query on that.
Yeah.
Yeah, I have a query on that. The thing is, whenever we do some proximal tibia fracture, we'll give a lot of importance to the medial column, plating it and everything. But coming to the calcaneum, the medial column, most of the fixations are on the lateral side. The medial column, which is usually the compressile side and where the slide usually happens, and we never try to buttress that. Is that something like a dual plating is a point?
Kamlakar, that's very important. What you mentioned, you see, again, the collapse occurs on the medial side, right? That's where it collapses. That is why you need to put that screw very skimming that medial. So it's actually internal plate. What you're doing with the screws, putting 2 or 3 screws, you're putting internal plate there. So it's skimming that medial cortex because that's where you have good bone there. So you don't want to come out medial to the wall. I think I've done that mistake couple of times. You took a good Harris view, you will say, oh my God, it didn't look as if it was, it looked as if it was on the bone, but actually I'm entering the bone and exiting the bone and entering again. You see on the medial side because of the curvature, you see. And if you do not get a good Harris view, you might miss it. I've done that mistake. So it's very important to get Harris view in a 2 or 3 planes, you see. So, you really want to make sure you can skim, you can go as close to the medial side, inside of the medial wall, and then shoot those screws, you see. So from posterior into the ST fragment. And it serves, like you said, it flies like a plate. It doesn't bend. And you are actually creating a medial buttress there.
Yeah.
With the screws.
Invasive. And with minimal invasive, like I don't wait for the wrinkle sign because sooner is better here,
Absolutely, yes.
Yes. Otherwise, if you try to do this at 3 weeks, it's impossible. So if you, at 2 weeks or 2.5 weeks, if I try to do minimal invasive, I start with the gastric first to bring the tuberosity down and doing the distraction, and like it's a struggle, but you can still attempt to do it, But here you don't need to wait. You can just proceed. You don't need to wait for the wrinkles to come back.
Full relaxation with the anesthesiologist. As soon as you can get in there. Last administration, I've done Achilles tendon lengthening. I've done sometimes because it's like I said, as soon as there is injury in the distal tibia,
talus, calcaneus, the muscles will contract because of pain and constant contraction of these muscles as a inhibition, as a pain response to the pain. You'll be amazed how quickly the soft tissues
They start
contract,
contracting.
and to fight them is very difficult. Very good.
Sorry. I think one more point, sir. When do you actually think of doing this gastric recession? Is it after you completely fix the talus, and fix the calcaneum, see the dorsiflexion, or you need to do in the beginning to get the tuberosity down? Any?
If I'm not able, I'm struggling. If it's an old patient, like Dr. Ashish Shah said, 2 or 3 weeks, 4 weeks, yeah, that's when you need it. If you don't need it, I will not put, after fixation, if you think there's a problem with dorsiflexion, you can certainly add it. But if I'm going to do it only if I'm struggling to bring the fragments down, if it's old fracture.
So we'll go with the case discussion on the marginated calcaneum, sir, now.
Okay.
Right. Just give me a minute. I'll share my screen. So this is a 60-year-old male of complaining of pain in the left foot for around 2 years, and he was having the pain was increasing on standing and walking. History of injury to the left heel was 20 years back and was managed locally by the quack. Patient was asymptomatic till 2 years, but now he is complaining of pain on and on, and which has increased for the last 4 months. So this is the exact site where he usually is complaining of the pain. Right, and this is his heel from the back, the wide end heel, and this is from the lateral. There is a bump over there, and he has some pain even on the posteromedial aspect too. So these are his x-rays, sir. So what would be the go ahead? Do we go only with the lateral bumpectomy, or do we need to do anything else? And what's your take on the ankle? First and foremost is, has it united?
So the thing is, if you look at it here, I mean, CT scan is the best if you can get it, and I would say you must get the CT scan here. But so this is what it shows, the everything, right? It was shattered like a watermelon thrown from the second floor and completely widened heel. So the question comes down to which approach you feel comfortable, okay? So the best approach, if you are comfortable with, then you do the posterolateral approach, patient in the prone position, okay? Or the lateral position. You can do the lateral wall exostectomy. That's number one. So basically, like, you can see lateral wall exostectomy, and then you do the distraction arthrodesis through the subtalar joint here. Using the allograft, there are higher chances of getting crush. I would use, if I'm doing the distraction arthrodesis, then I will definitely use the tricortical autograft from the iliac crest with this. I will do a little bit of medial to prevent the varus of this subtalar fusion thing. I'll prepare a little bit more on the medial side. Number three, when I'm doing this distraction arthrodesis, I will use a fully threaded cancellous screws, or at least first fully threaded and then, or first one compression and one fully threaded cancellous screw, because you don't want to be collapsing here. So this is very important. This is the case. I definitely add the gastric to begin with to help me out. The most challenge here, I mean, if you can, number of times people I've seen, they do with the lateral approach as well. You can do with the lateral approach. The negativity is like, when you open up, you can do lateral wall exostectomy. Stuffing laterally, the allograft or autograft, they're making the wound complication laterally. But I've seen people doing successfully laterally as well. with the lateral approach. In my hands, I do the posterolateral approach for this patient.
ब्लू कलर की है ना, ब्लू पेन में बहुत स्मार्ट लगेगी। ब्लू पेन, हाँ क्या ब्लू पेन? ब्लू कलर की टी शर्ट।
Hello. Hello.
पागल है।
Hello. Yeah. So my concern was actually this, does this fit into the type 5 of zip and runlet classification where there is a lateral sliding of the tuberosity? And in that scenario, does it take any value of doing an osteotomy through the fracture and getting the tuberosity back?
You can do, see,
Sorry.
yeah, it's very hard, all of this thing. I mean, going through the fracture and doing this osteotomy through that, you can attempt if you, depending upon your comfort level. In the past, along with the distraction arthrodesis, I've done calcaneal osteotomy along with that, basically lateral slide or medial slide, depending upon the deformity to get the additional correction. When the patient did not have this much amount of lateral widening, instead of distraction arthrodesis, I've done the plantar displacement calcaneal osteotomy as well. It's case by case, it can be different. But yeah, you can, if you feel comfortable, you can do it. But I'll be more of this distraction and adding the calc osteotomy with that.
Kamlakar, you mentioned in one of your talar fracture, the problem with the dorsiflexion. Here is a scenario wherein a person could have a problem with the dorsiflexion of the ankle. They may not be able to squat completely because you can see on the lateral, if you go back to the lateral X-ray, see the lateral X-ray, there's no range of motion possible for the dorsiflexion there, you see. So, and if you look at the Harris view, you can see how much of the tuberosity is in varus there. If you want to reconstruct all of that, because it has symptoms in the subtalar joint, the posterior aspect, and the problem, then one alternative is Romash osteotomy. I'm not sure whether you heard of that.
Yes, sir. The same thing I was talking.
That is absolutely, it does wonder. If you learn how to do it exactly, that guy has thought about the whole thing. Basically, he recreates the whole scenario, whole fracture. It's important to go to the primary fracture plane and really lever that fragment down. It is a lot of struggle. I use lamina spreaders. I use all sorts of things to, after you make an osteotomy, it's critical to go to that fracture plane, recreate the whole anatomy of the fracture, and then distract it. And once you distract it, you need to really get that fragment out of varus. Once you do that, you'll be able to pin that temporarily or with cannulated screws. And that is a really good, and then what that does is brings that talus down into better alignment with the first metatarsal. So it brings that talus into declination, rather than out of its horizontal thing. You can certainly do a subtalar in situ fusion, but after taking out the lateral wall, it's much easier for those who cannot do all that. But you need to remove the subfibular impingement. So you need to remove a lot of lateral calcaneal wall, lateral calcaneal exostectomy, and do a subtalar fusion if the subtalar joint is arthritic. Here, I think it's not that arthritic.
Yeah.
So you can, if you want a minimal invasive, minimal approach, and the patient is mostly, problematic in the lateral aspect, certainly you can do a very generous lateral calcaneal wall exostectomy and decompress the whole thing, and that will work too. It's not symptomatic about the dorsiflexion, plantar flexion aspect of it. But if it is required, so we can have either subtalar distraction arthrodesis or a Romachius osteotomy to bring it, reconstruct the calcaneus.
Yeah, and I think it's a 20 years old injury.
Seems to be articulating with the.
It's a 20 years old injury, and of course I don't think the Harris view shows any major varus or valgus deformities over there. I don't think any role of osteotomy here to correct any heel varus or valgus here. I think like what Ashish or Vinod said, the lateral bumpectomy and the distraction arthrodesis will do the job instead of recreating the anatomy.
Yeah, the same thing, sir. Yes, sir. Ajay sir, you can go ahead.
It's articulating with the lateral malleolus. It's formed a pseudo articulation there.
Yeah.
You can see the
Yes, yes,
protein,
sir.
like
Yes, sir.
an additional joint there. So
Yeah.
you at least that I think we'll have to. I think that removal of that bump I think should work because he's asymptomatic for 20 years. It's happened only in 4 months, and with a well-preserved subtalar, I would probably hesitate to do a fusion in this case. Just a lateral wall exobstructomy might be better.
Yeah. So the same point was on in our mind, sir, because it was articulating mainly with the lateral fibula. You can see the osteophytes and everything over there. First, we knocked it off. To our surprise, there was a good subtalar joint over there. The articular surface we can see down, but it is not complete. Actually, it is partial. So when we got the introp axial views, this was what we were seeing. So the actual worry was if we do a lateral bumpectomy here, the amount of articulation over here might be less. So this was the Romanage which was planned and do, but when we do the bumpectomy, the amount of articular surface and the bone left over might be less. The CT was showing the same thing. It was a lateral slide over there. The amount of bump removed will be this much. So we were worried about the leftover bone. So as discussed, we proceeded with the lateral distraction and put a tricortical graft there, got the alignment back, and we went in with the fusion.
Again, a great job. Great job.
Looks
Again, I
great.
like the way you used that fully threaded screws and also
Yep.
not parallel, non-parallel. So to keep the distraction, because what actually happens is if you use regular candidated screws in a parallel mode, it can collapse because it takes a long time for the graft to incorporate. If you look at the talus, you see it has got a little bit of articular surface anteriorly, which is really good. It's a great reconstruction. You got
But
the various.
It looks beautiful. Yeah.
But the point which was running on the back of the mind was the closure of this segment of the incision.
If you get it out in the varus, you see, it does not matter. If you get that out in the varus, right, if you leave that varus in, you will not be able to put that back. So sometimes, I use, yeah, I mean, the horizontal part of the L, you need to minimize that to prevent that. You see.
See,
if you get it out of the varus, then you will be able to close it.
see, that's the reason. Like I'm just doing the longitudinal Galley's approach, the posterolaterally, which runs between the sural nerve and the Achilles tendon. And you keep it patient in the prone. You can do the lateral wall exostectomy from the same incision and open up the posterior subtalar joint area. You prepare and snug the graft through that, So basically, you don't need to have this wound healing issues or stuff laterally because now you open up this much, I mean,
Yeah.
And majority of people I've seen they've done, the wound is healed, but this
Yeah.
is something like my training was, and since then I'm just doing this the posterior approach.
One question. Oh.
Yeah.
Yeah, would you like to add the anterior small screw that was described by Coughlin? The Roserman's description. The anterior screw in anterior facet to better compression of the subtalar joint.
So,
An
I
additional
think
screw in the anterior facet.
No, I think what Aditya, what was done, Aditya, the posterior facet is enough, So I think this is very sufficient because we don't really want to go into the sinus tarsi. Sometimes, Aditya, what happens if you mess up with the circulation, it might take a long time for this to fuse. So ideally, if you just fix that, go across the posterior facet and keep them in a non-parallel fashion, and also use a fully threaded screws. He has used acute screws. Kamlakar is really good because they are very strong, stable, and this is what I do. This is exactly what I do. But his osteotomy was very clever. In the way he put the osteotomy he was almost close to that previous fracture plane. See, that's why he got the varus completely corrected. In a 20-year-old kid, this is pretty good.
Thank you, sir. We'll go with the next talk on Lisfranc injuries.
Good morning, all. My topic today is the influence of medial and lateral column injury on the clinical outcome of foot injuries. As you know, the human foot is a complex structure. Functionally, it is divided into a medial column or the medial longitudinal arch and the lateral column or the lateral longitudinal arch. The stability of the foot is ensured by the rigidity of both of these columns, and each of the columns supports each other. Midfoot fractures involving these two columns have a high rate of mid and long-term morbidity. You can see that traditionally the foot injuries comprising the midfoot region have been seen either as a Lisfranc injury or a Chopard injury of the midfoot. However, it was disappointing to see that literature such had not shown any studies focusing on column-based injury patterns of the foot and or its effect on functional outcome. None of these studies has taken the column concept into importance. Here you can see on the left side, you can see a Lisfranc injury of the midfoot, and on the right, you can see a Chopard injury of the midfoot region. While doing a little research using the keywords middle arch foot injury, there are around 4 lakh entries in Google search engine and 60,000 entries in Google Scholar search. And a keyword using the lateral arch foot injury, they showed 4 lakh 40 entries in the Google search engine and 1 lakh 33 entries in Google Scholar search. While using the keywords midfoot injury epidemiology, there are only 20 studies we could make it out from PubMed search engine. But we could not find any study related to the functional outcome based on the column concept. And there is no data available describing disability associated with any individual column injury. Coming to instance of midfoot fractures in India, Dhilan et al. Has shown that 13% of all the trauma there was fractures in India, and the incidence of midfoot fractures in Western countries were about 3.6 to 10 power 5 by study shown by Court Brown et al. But percentage of the medial lateral column injuries and associated functional outcomes, we could not find any study describing such data. Coming back to the aim of the study, to determine whether the medial column injury or lateral column injury of the foot is more disabling for residual foot function. This is the main aim of our prospective study. And the methods and materials, we followed a strict inclusion-exclusion criteria. Our inclusion criteria included all closed or open fractures of the foot. Cases included were injuries which are occurring distal to the talar and proximal to the shaft of the metatarsals. This included the navicular, cuboid, the 3 cuneiform bones, medial, lateral, and intermediate cuneiform bone, and only skeletally mature patients were included in our study. Coming to exclusion criteria, patients having any congenital anomalies of the foot or residual effect of poliomyelitis, patients having pathological fractures, and cases in which there is sensory or motor loss due to associated head injury or paraplegia, diabetic foot, or Charcot's neuropathy were excluded from our study. Coming back, the patients were divided into 3 groups. Group A were patients having only isolated medial column injury. Group B were isolated lateral column injury patients, and Group C were both medial and lateral column injuries. We used the AFOS midfoot scale and the functional foot index revised scale to score our patients and find out the functional outcome. The tarso first metatarsal angle and the calcaneal pitch angle were measured. Follow-up visits were done even at 2 weeks, 3 months, and 6 months until the last follow-up. Informed consent were taken from every patient, and the patient performance was filled after taking up the consent. Coming to our observation, totally we had 71 patients in closed fractures were 26 and open fractures found in the majority there were 47 cases. Group A, isolated medial column injury 29 cases. Group B, lateral column injury 12 feet, and Group C, both columns are 32 feet. Coming to the mechanism of injury, the most common of mechanism was road traffic accident. It was followed by fall from height, and then other injuries were missile injury, railway injury. And majority of the patients, around 75%, are managed surgically only. 25 cases, that is around 34%, had ipsilateral lower limb injury along with the midfoot injury, while 6 patients, 8% had around contralateral lower limb injury. Coming to the fractures in medial column, the second and third metatarsals were commonly fractured, followed by the navicular, and the fractures in lateral column, fifth metatarsal was commonly fractured, followed by the cuboid. Around the 6-month follow-up, AFOS midfoot score showed a Group A at a 79.39 score, which was a better score compared to Group B and Group C. The same score was reflected in the functional foot index revised score. Group A having a lower score means a better outcome compared to Group B and Group C. So isolated lateral column injury had a comparatively poor score compared to isolated medial column injury and bicolumnar injury. Isolated lateral a completely poor score, but it was not clinically significant in our study. Isolated middle column had a better pain score, and the middle column also had a better walking distance score, and the middle column had a better activity score compared to isolated lateral column injuries and bicolumnar injuries. The functional score in elderly group was almost comparable to that of the younger age group, but there's no significant difference was seen in patients with ipsilateral lower limb injury who had, in addition to the midfoot injuries, when compared with isolated midfoot injuries. And we also could not find any significant difference in functional outcome in patients who had a surgical delay and compared to group with no delay, provided an operating condition, provided good anatomical detection was achieved. And coming to open versus closed cases, there's a statistically significant difference in open versus closed injuries, with closed injuries having a better functional score compared to open injuries. Here the p-value is less than 0.05, and so it is statistically significant in our study. And here are some of the pictures from our study. First picture, you can see a bicolumnar injury which was fixed with a partially threaded cancellous screws. Second row of pictures show a grade 3B open injury, which was managed by doing a flap injury and given an external fixator in the form of just. What have we seen in our study? In our study, young adults are more involved in road traffic accidents, and midfoot injuries were tending towards high velocity injuries with the increasing soft tissue crushing component. So from the traditional fall from slip and fall, it has gone to more of a road traffic accident type of injury. From our study, what we have concluded is the incidence of the complex midfoot injuries is on the rise due to heavy vehicular movement and increased incidence of road traffic accidents. Isolated middle conjuring injuries have a favorable functional outcome score compared to isolated lateral column and bicolumnar injuries. Isolated lateral column injuries had a poorer score compared to other two groups, and the bicolumnar injuries are more common and intermediate score. Problem was we could not assess statistical significance due to lesser number of cases in our study. It was just a small prospective observational study. But what we could say is no previous study has described the effect of injury or the consequences thereof to the longitudinal columns of the foot. The complexity of the injury rises. It is may no longer be possible to classify them as simply as a 4-foot, midfoot, or a 9-foot injury. The column concept enables assessment of the entire foot and is maybe more relevant in complex foot trauma. As in any study, we also have certain outcomes, shortcomings in our study. It was mainly a short-term study. Study was carried out in a tertiary healthcare center, so some of the lesser known injuries may not have reached our center. Small sample size with the minimal patients are found in group B. The study groups were heterogeneous, and no particular cutoff values are found for the functional foot index revised score system to grade them as a good, fair, or poor outcome. Strength of the study: the first study to focus on column-based injuries is the foot and effect of its injury. It was a prospective observational study. Surgeons having a sufficient experience in foot and ankle trauma were included in the study, and all our follow-ups were done under supervision of the same surgeon. We follow strict inclusion criteria to prevent any possible selection bias and eliminate possible confounding factors also. As you can see, this animal appears to be an Indian duck, but or was it actually? It actually was an Indian rabbit. So how you see it matters the most. So the column concept enables assessment of the entire foot and maybe more relevant in complex trauma. This should high time issues from just classifying the midfoot injuries as a traditional wrist frank and toe part injury, and we better to switch into column-based concept, dividing them into middle column and lateral column injuries to give a better assessment of the entire foot in complex foot trauma. Thank you so much.
We'll be going with the next talk with Dr. Sundararajan, sir, and we'll have the Q&A after that.
Lisfrac injuries, fix or fuse. This is one of the commonly missed fracture in the foot, and most often this treated is considered a sprain, and usually patients present with late instability and disability. So Lisfrac injury, what do you mean by Lisfrac injury? It's a fracture dislocation of the dorsal and metatarsal bone complex, or sometimes it could be just pure ligamentous injuries involving the midfoot. It is very important to understand the anatomy of the three-column concept, whereas we know that medial column, middle column, and the lateral column. Medial and middle columns are very rigid and they don't have much movements, but fourth and fifth has got some mobility. So we always, when you do a management, fourth and fifth, we try to preserve the motion, and first and second, third can be fused. Sometimes it is very important to understand the anatomy before you go proceed for the management. Here we have three ligaments. One is the dorsal ligament, plantar ligament, and interosseous ligament. That is the Lisfranc ligament. That is the strongest ligament. I think that in biomechanical studies had shown that that is the most common and the strongest ligament holding the medial cuneiform to the second metatarsal. When you come to the mechanism of injury, you can have a direct injury or an indirect injury. Coming to the classification, according to the Myers classification, you have a type A is a total incongruity, partial incongruity where you can have a lateral side or the medial side, divergence where one side can have a medial dislocation, other side can have a lateral dislocations. The Nunley classification helps to understand the ligamentous injuries where the stage 1, there is no diastasis. Stage 2, there is a diastasis between the first and second metatarsal. On stage 3, apart from diastasis, there is a collapse of the medial arch in the lateral view. When the present clinically, high energy injuries always obvious because of the pain and swelling. But when you have a low energy injuries, you need a lot of suspicions because swelling may not be very obvious. Plantar ecchymosis, one of the sign for a Lisfranc injury to identify. Sometimes the patients can have a feel of pop sound. The imaging, you can take an AP view, which helps you to identify the middle column, where the medial border of your second metatarsals aligned with the medial border of the second middle cuneiform or second cuneiform, and 30 degrees oblique view and helps to identify the radiographic parameter where your lateral border of the third metatarsal aligned with the lateral border of the lateral cuneiform, and the medial border of the fourth metatarsal aligned with the medial border of the cuboid bone. Of course, weight-bearing X-ray helps to identify when there is a collapse of the arch, wherein normally you will be able to see the fifth metatarsal, but when there is a collapse, you will not be able to see the fifth metatarsal in the weight-bearing lateral X-ray. So this is very, very important to take a stress radiograph in weight-bearing, especially when there are pure ligamentous injuries, to know the diastasis. It is very, very important. Sometimes you can have a flux sign, which is an avulsion of the Lisfranc ligament, indication of the Lisfranc injury. So CT scan sometimes helps you to identify when there is a comminution, to identify and know the articular cartilage damages, and also to detect associated fractures, which will also help you plan the fixation, whether to do a fixation of the anatomical reduction and fixation or a fusion. When can we consider these injuries? Whenever there is a less than 2 mm displacement of the dorsopetatarsal joints in any plan, you can treat conservatively with the plaster or boot can be applied for 6 weeks time. Whenever the displacement is more than 2 mm, fracture dislocations, we need the surgical management. What you do to whether to do an arthrodesis or open reduction internal fixation with the screws is the major important and controversial questions in the acute cases. When you have a 5 dorsal injuries like this, where all the 5 were involved, but there is no comminution. So you can see both medial, middle, and lateral column are involved. Here you can use the 2 incisions, or sometimes you can even use the 3 incision. Dorsal incisions in the 2 dorsal incisions, and also along with you can add sometimes another medial incision, but you have to be very careful that bridging of the skin. So you should have enough bridge so that they don't go for a avascular necrosis. They don't go for the necrosis of the skin. Whenever you do a fixation, so it's important to do a reduction, make sure that the alignments are okay, then fix the medial cuneiform to the second metatarsal to the screw, so that gives the course of the Lisfranc ligament, gives the more stability. Then you can additionally add the other screws to fix the first and second metatarsal joints, tarsometatarsal joints. Here, as you can see that we fixed the first, second, and third tarsometatarsal joint. Fourth and fifth, we try to preserve it, the mobility. Then we put it on the screws, and the screws can be removed after 4 to 6 weeks time. Can we use K-wires alone? If you see this case, surgeons have used only K-wires, but the most often they can go for a displacement because of the your Lisfranc ligament has got a lot of force over the tarsometatarsal joints. They cannot hold these, and finally they'll have a recurrence of deformities and loss of reductions, end up with a disability. So when to do a primary arthrodesis in acute cases, you can see this example of 55 years old male had an injury from a two-wheeler. You can see these cases, even though the tarsal metatarsal joints are injuries are evidence, here also you can see that the joints are completely distorted. That means articular surfaces might have been damaged. Here, wise to fuse the joints rather than fix, and also CT scan helps to identify the comminution and involvement of the joint surfaces. Here, you can see the first reduction was done with the multiple KOS. Make sure that you have all alignment, then do the fusion of the medial and middle column. Here we had used the dorsal plates. For the first and second, we use this kind of plate, and the for the third tarsomotatus joint, use a single plate, and fourth and fifth just close reduction and K-wire. Even though fused on the medial and middle column, we try to preserve the motion on the fourth and fifth so that the patient will not have a lot of stiff foot, midfoot. What about the literature? There are two randomized studies. You can see that between the open adduction and primary arthrodesis, where the first study for the JBJs in 2006 had shown that 92% of the patients went to the pre-injury level compared to the 65% in the pre-injury level of open adduction and internal fixation. The other paper in the Foot and Ankle International in 2009 had shown no difference in the functional scores. However, the reoperation rates are higher in the fixation group because these patients needed an implant removal, or these patients developed arthritis and went for fusions. So still the fusion is the, still you can have a choice of surgery whenever there is a, in acute cases, especially when they have a dislocations, or if we suspect the articular surfaces are damaged, better to fuse rather than fixation. What implants to use? K-wires already we told, better to avoid because of the chance of displacements and the infection. And the cortical screws can be used, or sometimes the dorsal bridge blades can be used. There are studies that had shown that sometimes this paper had shown that dorsal plates have better functional outcome, and also they can be used in comminuted fractures. The preferred treatment, still you can do an open reduction and internal fixation. If you do a proper fixation with the screws or the dorsal plates, make sure that all the radiographic parameters are fixed, obtained, then there should not be any problem. Whenever there is a late presentation like this case where they presented after 8 months, sometimes when the x-rays may not be very obvious unless you take a weight-bearing x-ray and compare with the opposite side, then you know that the diastasis is there. Here, there is no controversy. Directly, you can go and fuse because it's an 8 months old injury, and you can see the complete consultation at 5 months follow-up. To conclude, Lisfranc injury is often missed. Must be aware of mechanism and signs of injury on examination. Anatomical reduction is the key here. Both screws and dorsal plates can be used, can give an equally good results. Better to consider primary arthrodesis if there is an intra-articular fractures, unstable dislocations, and late presentations. Thank you very much.
We'll be having the next talk by Dr. Ashish sir.
It's a great talk. Like, you know, the take-home message, like in my practice, like number one, weight-bearing extras, if patient can weight bear, or if there is any time there is a tenderness in that area, you should be suspicious about the Lisfranc injury with the acute presentation. Number two, if the patient can afford, if X-ray looks normal, then you can do MRI. But if to look at the Lisfranc injury, but if there is a diastasis and you see there is a Lisfranc injury, you should always do CT scan, because you'll be amazed that even though you fix the Lisfranc, these patients are still in pain because they got the comminuted fracture, intra-articular fracture through the fourth and fifth tarsometatarsal joint or other tarsometatarsal joint. So you should always do CT scan to look at it as well. In my practice, all of if I'm doing ORIF, it's a younger population, sports population, athletes, then I prefer to do plating system. So I can save the joint without passing the screw through that, like, you know, dorsal plating, 2-hole plating. And this is more like a stabilization plate, not the compression plate. And then Lisfranc screw, as Sundar mentioned. And all of my patients with the middle age, non-diabetic, non-smoker, late presentation, I prefer to do fusion, one-time surgery, heal. We don't need any more surgeries in the future.
Yes, Ashish, I think as you said, here many times, most often it's missed as a sprain, even especially in a pure ligamentous injury with the small comminutions. they often missed, and usually they present late to us, maybe after 2 weeks or 3 weeks or 4 weeks time. And many times, but yes, he said that they are very middle-aged patients or old-aged patients, and my surgery mostly often fusion them rather than I go and try to fix them and the later on, so that they may not need to end up with arthritis or fusion. Of course, the CT scan is the foremost important whether the in acute cases, especially when they see only diastasis. Sometimes when you do a CT scan, you can see the articular surface will have been involved. So your management can differ from fixation to the fusion. So the CT scan plays an important role.
Can I talk about list strength injury a little bit? You mentioned investigations. One of the most important investigations I feel is to determine if there is a stable or unstable fracture. Obviously, when there is a severe fracture dislocation, a plain X-ray can tell you all those things. But the difficulty comes in when we're not sure. We can see a ecchymosis or may not be ecchymosis. Patient is able to walk, not able to walk, or is painful but swollen in the midfoot. We don't know, and is not able to put full weight on it for you to see the diastasis. If the patient cannot put full weight, even if you have weight-bearing X-rays, they will not be able to reveal the diastasis. So those are the kind of situation you do not know what to do. But if it's unstable injury, you cannot leave it alone. You have to stabilize it. So how do you determine what's stable or unstable injury? Sometimes it's difficult to, unless you have a weight-bearing CT scan, you will not be able to see that. So a stress X-ray will let us know, or bring the patient about 2 weeks down the line when the pain is probably more tolerable. And if they're able to stand on it, they can reveal the diastasis. If they reveal the diastasis, then it is it. That's unstable injury. So again, I favor, like Dr. Ashish Sase mentioned, obviously we started off with putting K-wires across the joints and then the screws across the joints. And then we now moved on to putting plates across the joints. We'll call it a spanning or bridging plate rather than, putting screws through the articular surfaces of the pristine joint. Why do you want to do that? The other thing, I've noticed sometimes when you put this screw from the medial cuneiform into the base of the second metatarsal, what you end up doing is distracting the very place where you don't want to have a distraction. That is the space between the medial cuneiform and the base of the second metatarsal. So if you're putting the screw from the medial cuneiform, even though you put a clamp, you think the clamp will hold it. But as you're screwing that thing in, you end up distracting the base of the second metatarsal even by a millimeter. So that can lead to so if you flip the screw and start the screw from the base of the second metatarsal and put it in the medial cuneiform, you don't do that. You actually bring those bones together. So, that's my suggestion, in case you want to try that. Really, there are lots of advantages.
And Vinod and for Ashish, my question, especially the pure ligamentous injury, sometimes I see the patients after 3 weeks or 4 weeks time that come late, especially the middle age or less active old age patients. Sometimes even though if the criteria keep it 2 mm, sometimes even they have a more than 2 mm diastasis, I try to put them on a comfortable footwear. Many of them will not come back. They say that after 2 months, 3 months, they said, okay, I'm all right. How aggressive are you in doing fusion in these cases?
That's a good question, Sundar. Again, we try not to treat the X-rays, we treat the patient. If the patient tells me I'm able to live my life, what the hell are you doing in my clinic? Get out. If the patient says, no, I still have pain, I'm not able to do this and that, I can't stand or walk or do my shopping without having to sit down, that's when, yes, you have to do something for it. And then if they're like 8 months out in the injury, then the best thing is to fuse them, I think, because trying to get the ligament to heal at that stage may be difficult.
My patient, older patient, diabetic patient, you see diastasis, ligamentous injury, but asymptomatic. After calming down their acute episode, if they say, hey, I'm doing well, okay, just come back when you're hurting. There is nothing wrong in just keeping a close eye on it or treating when it's needed,
Any role for the tightrope in ligamentous injury?
We actually did a study which was published in JBJS. We compared the screw with tightrope. We got a funding from Arthrex, and we got, but you see, it worked very well on the lab. The screw was as equal as the tightrope, but and I started putting on the patients, but the tightrope becomes loose rope. You see, so basically, the tightrope, the concept of tightrope is the endo buttons on the bone. Both sides have an endo button. What happens if there's a constant pressure on the bone? The bone resorbs under the endo button. So then the tightrope by design will not stay tight. A screw works in a different way. The screw with the bone, it does not resolve. So it provides a stability constantly. So a tightrope for a list rank, I think, trying to bring those bones together and keep them together long enough, I think it does not work. I have actually failures from tightrope.
Seen some people using, or I've done a couple of times with the patient with the like 400-pounder or higher, using removing the list rank screw and switching with the tightrope, or some people do that. But no, I agree with Vinod. Like I don't use tightrope for the definitive fixation primarily.
If the next thing to do is fusion.
Sir, regarding the rehabilitation of such injuries, so do you recommend modification in the footwear? Like, do they need a middle arch support once they start weight bearing?
That's a good question. That's a really good question you asked. By the way, your presentation was good as well. So, and before I forget, did you take AOFS scoring?
Sir?
AOFS, you should not do that. The AOFS has been retired, so you need to go for newer scores, like Dr. Ashish has done FFI or
FFI score.
So AOFS, do not use it. You will not be able to publish that anyway. So what was
I
the question?
took both courses.
Orthotics is very important. So even though you got it fixed, you need to use a total contact insert or a carbon plate for up to a year. You need to protect the patient for up to a year, so that otherwise late collapses can occur. Good question.
And the Lokesh, I think on the injuries which you have studied, most often they are the open injuries. How many of them are open injuries? How many of them?
Like 75% are open injuries. Sir.
Yeah. So whenever the soft tissue takes over the bony component, I think many times the bone doesn't have a major role over there, especially when you do a plastic surgery, do a flap cover. So by the time even the bone doesn't heal or distorted, it doesn't matter in foot. I mean, in my opinion, because we tend to see a lot of open injuries with a lot of even column loss, medial column loss or lateral column loss. They tend to do, especially our patients, they tend to very well, even with the barefoot, they walk with 3 rays or 2 rays. So I think the footwear is very, very important in that injuries, but I don't know how much the bone can play a role in have a soft tissue injury takes over the bone. The influence of this bony injuries, I really am not sure how much it is going to affect the functional outcome.
Now we'll continue the discussion after Dr. Ajoy sir's talk. So that would be the last one.
Well, greetings everybody from Bangalore. I'm Dr. Ajay, and at the outset, I would like to thank the organizers of the OSS for having invited me to participate in this foot and ankle section of the meeting. So, after discussions with Dr. Kamlakar, we had kind of zeroed in on this topic as to whether we should be fusing the first MTP or retaining the movements at the MTP joint whenever we are discussing about or dealing with arthritis of the first MTP joint. And so that is when we felt that we should be having this. So let me just share my screen. Yes, so fusion or motion of the MTP is what we should be looking at. So on an overview, so there are various etiologies which can contribute to the formation of an arthritis at the first MTP joint. And let us look at all of them, or some of them at least, and what options do we have for treatment, and what indications are there for fusing it, what indications are there for preserving the joint, if both are useful procedures or not. Just summarizing the whole thing and coming to a conclusion as to what we should be dealing with when we're having a situation like this. So degenerative arthritis is one of the most common etiologies. So very often we see people with hallux rigidus. Often it goes undetected, but then it is definitely there. A significant incidence is noted. Very often we also deal with some post-traumatic arthritis, and we also encounter a lot of hallux valgus and varus deformities which are in the late stages. Now this is something very peculiar to our subcontinent, and because patients tend to neglect them and because they use open footwear, they generally postpone visiting the doctor despite having a deformity until unless it gets extremely painful and when they're at the stage of an arthritis. Inflammatory, of course, arthritis can of course happen at any age group and across any place, and is one of the indications for the arthritis of the first MTP joint. What options do we have for treatment? We can either preserve the joint by means of either performing a chelectomy wherein just the osteophytes can be removed, or using some newer techniques such as the Kativa, or we can perform some osteotomies wherein we can preserve the joints without having to go for fusion, or we can end up doing the arthrodesis of the first MTP using plates and screws, which is probably the best method of doing an arthrodesis. Going through the literature, we could just see that joint preservation is something which is being dealt with since the year 2007, and especially in the case of inflammatory arthritis, wherein rheumatoid forefoot, the prior treatment for this, the classic surgical approach, included only fusion and of the first MTP and resection of the lesser metatarsal heads. Different kinds of osteotomies have been coming up, and it's Farouk's paper of 2007 which kind of sets the ball rolling in this favor. Then looking at other articles also, whether we can preserve these joints or we need to actually sacrifice them. I think different people have come up with ideas which have gone in for preserving the MTP joint in the case of inflammatory arthritis or rheumatoid arthritis. But when you're looking at the fusions, so I think one of the recent articles which has come in is regarding the effects that a fusion would have on the FDL. So this was a cadaver study which was performed, and they found that MTP fusion causes some amount of loss of power of the FDL because it goes along with the FHL at the knot of Henry. And others have also found, none other than Brodsky, they had found that performing an MTP fusion using different techniques actually is a reliable procedure, and not much of a change or gait characteristics or functional evaluation would happen if an MTP arthrodesis is gone in for. Now, India, we do encounter situations like this, wherein the deformity is quite gross. This is a inflammatory arthritis. This is rheumatoid arthritis. The patient is somewhere around 74 years old. She's got extremely painful now, unable to walk. And in these situations, I think a fusion would be, and the correction of the deformity and the fusion would enable this patient to walk beautifully. And deformities like this, wherein you can see hallux varus, which has been existing for quite a long duration of time, preserving joint preserving might not work, though we are dealing with an inflammatory arthritis. And when we are dealing with some hallux rigidus like this, wherein the patient has got an extreme limitation of the dorsiflexion, and X-ray pictures which are similar to this, and a clinic and on the surgical intervention, we find that she has such bad arthritis. I think beyond a fusion, we would not consider any other facts at all. So a fusion definitely in these cases would be a very good option. And when we are dealing with an hallux varus, or which is like this, wherein the entire phalanx is dislocated downwards, the MTP joint is completely arthritic, and there are so many loose bodies and osteophyte formation. I don't think this would be an indication for trying to preserve the joint, and we would definitely go in for some kind of a fusion because we know that we will get predictable results in this patient. At the end of 2 years, we can see that she has continued to be back to her feet and has got correction of most of her deformities. She also incidentally had a flat foot which I had corrected. And we can see that the telltale mark is only the presence of a increased pressure over the first MTP, and this probably resulted from the position in which the MTP joint was fused. So that I think is actually what the MTP fusion is all about. And how do we go about an MTP fusion? So just going through the different procedure, different steps of the procedure. This was an indication where the patient had an incongruent hallux valgus with gross osteoarthritis of the first MTP joint, and that's the deformity which he was having, and that's the pain that he was complaining of, including the Morton's neuroma. So, and the early formation of a hallux of the hammer toe also. So in this patient, I think the best way to do was to probably go ahead and fuse the joint. So this is what I did. I positioned the patient in this fashion, and that's the incision which I take, which is just medial to the EHL. And once I do that, I identify the entire joint. And once I've gone down, prepared the joint completely. This is by means of using the cup and cone reamers. So that's the central position which we have found and image on the X-ray. That's the cup and cone reamers, which are specific to this particular set of instruments, and which gives a very good surface so that we can correct all the deformities, and at the same time we can match the surfaces very well. And once that is done and the plate is placed there and a temporary K-wire is done and held, by fixing the plates in the regular position, routine position, we are able to achieve compression, and we can also achieve the position that is required of the desired amount of dorsiflexion which is needed. So that once the desired amount of dorsiflexion is achieved, the compression can be relieved, screws can be put in place, and then we should be able to complete the fixation and see a very good result of this. Patients generally do extremely well. They are able to walk comfortably from very early, and then on they complain of very minimal pain. So this is what we can actually be dealing with by performing an MTP infusion. But then when we have instances like this wherein patients already have an arthritic joint, but then there is some amount of a cartilage which is preserved, I think the best option would be based on the classification to either just go in for removal of the dorsal osteophytes and then restore the range of movements, or we can go in for some kind of a preserving surgery. So this is one of the other patients wherein just a chelectomy was performed, and at the end of the chelectomy, a good range of movement was obtained, and the patient was symptom-free. Another patient wherein the dorsiflexion was slightly limited, very minimal changes of hallux rigidus here. So this was the X-rays which were seen for this patient. So I think the best way out was here to preserve the joint. And in this case, apart from doing the chelectomy, there was a new instrument which was available there, a new thing called as Cartiva. So this is what was this. This was performed by Dr. Coughlin when I was visiting him 3 years ago, and that's when I had taken these pictures, and I'm using the same pictures here. So that's the Cartiva which has been used, and at the end of this, the patient had got a fairly good range of movement at the MTP joint. So when we are just going through all this, so both options being explained to you. So depending on the disease etiology, we can either go in and the stage of the disease, we can consider the options which are available to us. We can either go in for an MTP fusion, or we can go in for preserving the MTP joint based on the etiology and the stage of the disease. So I would like to conclude by saying that both of these are very good options of treatment in given indications. And when the procedures themselves are well performed, I think the outcomes from these would definitely be better. Thank you so much.
Okay. Yeah, I think it's an good, excellent talk. One small query from my side, sir.
Yes, Kamlakar.
The query from my side is how would we decide the angle of fusion? Is it the plate deciding, or we need to have a variability depending on the patient needs?
No, see, okay, the plates themselves are available in three different angles. There's a 0 degree, there's a 5 degrees, and a 10 degrees, which is available with this particular set. I think somebody who wants to, I think on an average, I prefer the 0 or 5 degrees because that gives a good toe off whenever somebody is walking. I think it's very easy to walk off very well with a 5 degrees. But then somebody wants to use very high heel footwear and all, I think probably a 10 degrees would be better in those cases. Dr. Ashish or Dr. Vinod, I think can think.
Position is very careful. I mean, very crucial with this thing. The disappointed patients are if you leave them very dorsiflexed or very plantar flexed. So every foot is different. Some patients have a fixed foot, some people have a flat foot. So you might require a slightly different angle in some patients. Like Ajay said, if you really a very short statured person, if you really want to use high heels for women, you might require actually a bigger angle. But it's important not to bend the plate though. If you bend the plate, what ends up is that you dorsiflex, unless you intentionally want to do that. Because you need to understand the plantar surface anatomy of the proximal phalanx. Nature has designed the proximal phalanx in such a way that the plantar surface of the proximal phalanx is at the inclination. The dorsal surface makes a straight line with the metatarsal dorsal surface. It's the dorsal surface of the first metatarsal and the dorsal surface of the proximal phalanx are in the same plane. There's no angle between them. So, but if you create an angle, you sometimes end up with a problem. Some plates come up with a 15-degree angle. I actually change the angle and then make the plate straight plate. So, again, when you take a simulated Ross table, you want to make sure that the dorsiflexion is the kind of dorsiflexion. The big toe should be able to touch the foot. Otherwise the FSL becomes functional. So paying attention to how you place, especially in dorsiflexion, plantar flexion, is very critical. Some of the dissatisfied patients are those wherein you left it very dorsiflexion and they create a straight toe and the big toe gets rubbed in the shoes. And you also mentioned, Ajay, about the Cartiva. I think there's a lot of initial enthusiasm with the Cartiva, but we're seeing a lot of failures with that, you see. So, again, for hallux rigidus, there are two main operations that work very well. In early stages, hylectomy. In late stages, fusion. People have tried all sorts of replacement, tried this, soft tissue coverage, and so on and so forth, that have not stood the test of time. Unless a person is a ballet dancer, really needs that joint for some reason, fusion has served us very well. I think for Indian scenario or any other scenario here, I tend to sell the fusion a lot more. We have used Cartiva, have taken out quite a few Cartivas and changed into fusion. And there are only the people who started this whole Cartiva business seem to get good results. Everywhere else, results haven't been pretty good with the Cartiva, that hydrogel thing.
Yeah.
It's good for a year or 2 years, maybe 6 months, but after that it collapses. Nothing works very well in that joint, you see. The joint is uniquely placed. Unlike the hip joint and knee joint, wherein you have axial forces, this joint is lying horizontal on our foot. And dorsiflexion, plantar flexion, you put a lot of tremendous force there in different ways, you see. So nothing has survived. People have tried hemi replacement, metal replacement, Swanson, nothing has survived over time.
totally agree with Dr. Panchbhavi. Again, like, more and more neutralization or 0-degree plates we see more often, except some indications. Uh, Second thing is, uh, when you look at the literature, they say, hey, keep 5 to 10 degree of valgus, but you need to give little consideration to the valgus interphalanges coming from the proximal phalanx of the IP joint. Number of times, like, you have hallux valgus interphalanges through the IP joint. So if you try to keep the angle of 5 to 10 degree valgus through the MTP joint, now what will happen? Your big toe will rub against the second toe. So it's not that what the literature say. It's more of like, when you are doing the surgery, you see what makes sense clinically. It differs patient to patient. Majority of time it remains the same, but differs from patient to patient as well. The second thing, Cartiva, same experience. If my patient begs for motion and they're okay with additional surgery in the future, Cartiva is good. But otherwise, empty perfusion, people try to stretch the indication. Big bunions that you showed, they did the osteotomy, and with the arthritis, they put the Cartiva in it. Big disasters, big failures. So just do the surgery, which works with the amazing success rate. Keep patient happy, and you can sleep in the night.
Thank
Yes.
you.
With that, we'll go forward with the case discussions on Alex Valgus and best covers by Dr. Aditya. Thank you, Ajay sir, for the excellent talk and always being my support.
Thank you.
Hello, Aditya. I think voice.
Am I audible now?
Yes, sir. Yes, sir. Please share the screen, sir.
Yeah. So this is how the picture looks of the child. And this is the cavavirus deformity that we have seen. That's evident here. The left foot.
Switch on the camera, you.
Okay. Yeah. So this is the examination part. I took a neurologist examination to know the progressive nature of the swelling, nature of the deformity. So whether the deformity is progressive, should I do one thing? And this looks a flexible deformity. There is a Coleman block test, as you can clearly see. It's a flexible cavavirus deformity. The motor examination shows that the tip post and anterior tibial, the power is good, but the parens brevis and parens brevis power was zero almost. So there is no sensory deficit from that side. And this is a video how the walking looks. So as you can see, she's walking on a lateral column, and she's bearing her foot in lateral column, and there's no much of dorsiflexion weakness. The dorsiflexors are working, and yeah. This is the X-ray, weight-bearing X-rays. I didn't take any NCS, nerve conduction studies. I didn't do any nerve conduction. This is the weight-bearing X-rays. And I tried some orthotic treatment. I gave customized orthotic. The patients, the parents are so apprehensive, and the deformity is progressing. It doesn't show any, because she is bearing on the lateral column. I thought surgery would be the best option. So there is no much reaction extensors and varus. So the physis was open. I didn't contemplate any bony procedures. So the plan was to do a longest to brevis transfer, and because tibialis anterior is overacting, it's a hyperacting. Like I thought split the tibialis anterior transfer to contract the inversion, along with plantar fascia release to contract cavus, and gastroc to the equinus. So these are the intraoperative pictures, the gastroc and the longest to brevis transfer. And this is a split anterior tibial transfer. Post-op protocol is used splint for 2 weeks, where it is converted into a cast and allowed in the cast for 3 weeks. The button and the cast were removed after 6 weeks. Sorry, didn't add it. And feature and guide training has started. And the AFO is given further because we don't know the progressive nature of the swelling. It could be a cerebral palsy, not a progressive nature, but we don't know. So I've given AFO for her further thing. This is the follow-up clinical picture. It looks better. The varus is corrected a lot, and she's able to walk better. And these are the different videos. This is a pre-op video. This is after 2 months. This is the latest video, 7 months post-op. She can see that she's walking almost normally. Yeah, thank you. So, shall I go for another case? So this is one of my failures. Just wanted to know what went wrong with that. I know that in case of the 60-year-old female presented to me with a progressive deformity since 10 years or so. She had a severe hallux valgus, you can see, and there's a pain on the bumper part, and there is a metatarsalgia of second and third toes. These are the weight-bearing X-rays, and her IMA angle is all about 20, and which is very severe. Comes to severe hallux valgus. HVA hallux valgus angle is 48.6 degrees. So I offered her a surgery, a reconstructive surgery. And before that, I had tried all the non-operative treatment like footwear modifications, and all this failed. So the plan for surgery is to do a lateral release and mid-exhaustectomy as usual. And scar vasectomy was what I thought of, because it's a severe deformity. And also along with that, Aiken, because I felt there is a little IP angle deformity too. So Weil's osteotomy and hammer toe correction. That is what the plan. And this is the first. I'm able to pull the varus, pull the hallux to varus position at least 5 degrees after releasing the lateral. As you see, I didn't take in lateral incision. I thought I released it from the medial side itself after exhaustectomy. So, and this is the scar osteotomy. Under that, in fixation of screws and vials and all. This is the immediate post-op. Looks fairly okay for me, fairly okay, but 1 month post-op, she gradually started, the deformity started gradually recur, and this is a 3 months post-op, the present picture. So just wanted to know what went wrong with this case, just discuss further these issues. So, but metatarsalgia is reduced, the deformity is recurred, and wanted to know with the what went wrong with this case. Thank you.
Aditya, great cases. This hallux valgus thing, I've been doing this correction of bunion deformity for many, many years. I've had my set of failures and my set of successes. Okay, I've tried all sorts of osteotomy. Started off with Mitchell's osteotomy. I was that old. Mitchell's osteotomy, then went on to Scarf osteotomy, Ludloff osteotomy, Wilson osteotomy. And, finally I figured out no matter what you do, how you do is more important. This is one particular area of surgery where there are two aspects. There is a technique and there is a technician. Okay. So you may be a great technician with some techniques, but sometimes it may not be so. I'm not saying that this particular case failed because of the technician problem. Okay? So it could be the technique of that particular foot. Sometimes it is a technician. So I myself have failed as a technician in some scenarios. Sometimes the technique fails you, sometimes the technician fails. Do you understand that? There's a little difference between that's why, in people say in my hands, this applies very well in this scenario. Alex Wallace, there's more of an art than a science as far as I'm concerned for Alex Wallace. So now 99% of times I use Chevron and Aiken, but the way I do Chevron has been refined. It's not the way somebody else has done Chevron for that particular patient would be so different than me. So I have been able to correct all sorts of deformities, even the severe. We actually published in our 40 degrees angle, 18, 20 degrees angle. I've been able to do that with Chevron and Aiken osteotomy. Occasionally, if there is a patient who has midfoot problems, I have done Lapidus. I've moved on to do some Lapidus, midfoot arthritis, midfoot instability, are very, very flexible patients. I've done midfoot arthrodesis along with correction. Aiken is a great friend of you. I think, the Z osteotomy is the trouble is, you see, you shift it, but you're not really shifting it enough, because the proximal end of the cut obstructs it. With Chevron, if you angle the cuts in such a way that you can not only, you can angle the same way as those Scarf mentions, you can plantar flex the head, you can translate it, you can rotate it, you can do all that with Chevron, but with longer dorsal leg and shorter plantar leg, you can do everything you can what a Scarf does. In my hands, there's been a successful. So every time any patient, I show, if I have a lot of talks on hallux valgus, I can show an X-ray and 10 of you will say 10 different solutions for that. Somebody will say Scarf, somebody will say Lapidus, somebody will say everything else. But I say Chevron and Aiken. It has worked very well in my hands, so I'm going to do that. And it's the thing is, we really don't know what actually matters to the patient too. Sometimes radiographic outcome does not follow the clinical outcome. So even if there is a slight, recurrence of hallux valgus, so if it is, it was 40, you changed it to 15, but it came back to 20. The angle, I'm talking about hallux valgus. Is that a failure? No, patients love it, because the bump pain is gone. The toe is not exactly straight like a straight line, but it's deviating towards the second, but it's not overlapping like it used to. They're still happy. So we shouldn't be so fixated about the radiological relapse unless it's symptomatic relapse. Do you understand the difference? I'm not sure whether that patient which you did, obviously the joint is not congruous. I see that there might be a trouble from there, or sometimes, if the sesamoids, as long as the sesamoids are under the head, we are okay. If the sesamoids, the head is out of the sesamoid sling and you're overloading the second and third, that means you haven't done a good job for the first ray. So as long as the first ray is maintained, even if it's a slight relapse of the angle, it's not a failure. So where did the question coming back, where was it wrong? I don't know. Sometimes whether it is the technique or the technician.
So one question, sir, how do you correct your rotation with your Chevron?
Aiken is your friend. Obviously, once you release the, again, you have to determine where the rotation is coming from. You know, is it the rotation because the tendons have rotated the proximal phalanx? You know, because of the adductor tendons, is it deforming force there, rotational and also abducting force. So if you release the soft tissues down there, the rotational deforming force is gone. And then you decompress the skeleton, that also helps in removing the deforming rotational force. But if you end up shortening the first ray, then you should successively shorten the second and third and, you know, rest of the rays too by doing metatarsal neck osteotomies. If you don't, then you're overloading the second and third.
Yep. So I agree with Dr. Panchbhavi. Bunions are one of the most difficult. If you are just relying on the X-ray, then you will say, "Hey, this is the worst surgeon that I have found." You know, if you look at the 10 X-rays collectively, but if you're looking at clinically, X-ray might be looking terrible, but clinically, patient might be very happy. You know, like when I was trained about 12 years ago by Angus McBride, he will do Chevron and Aiken only. His X-rays used to look terrible. His patient used to love him because patient can walk from the first day. So again, like I didn't have balls to do that in the beginning of my practice, you know. Right now, for this case, let's say in my hands, I would have done the Lapidus for getting compression. I mean, big correction of the deformity along with the Aiken lateral soft tissue release. But I had the same presentation patient. One side was this type, both sides same type of presentation. One side I did MTP fusion, other side I did the Lapidus. The patient, I did the MTP fusion in the second setting on the second foot. He said, "Why didn't you do the MTP fusion on the left side to begin with?" So it's basically you are treating the patient. Everybody, you cannot treat each and every patient with the same algorithm here. Number two, Chevron. My patient's age group more than 60 plus, obese. I know that they are not going to be reliable. I just do Chevron and Aiken. Easy. I can sleep. Good clinical correction with the good better plates here in US, the pocket hole plates. We are able to do a little bit more correction with that. Like, you know, initially the regular Chevron you can do just a 6 millimeter correction, but with this you can stretch up to 8 or 9 millimeter. And the way we know mentioned, like, you know, that with the boat osteotomy or the longer plane, you can do better correction, more correction. And my 75% makes a Chevron and Aiken now, and 25% Lapidus.
Sir, one question. So, do you anytime consider doing DMMO instead of wheels?
Say it again.
Instead of wires,
DMMO instead of wheels.
Metatarsal.
It might be the proximal metatarsal, I guess, or the mid shaft osteotomy.
Oh, you're talking about percutaneous?
He's talking either while osteotomy versus the mid shaft osteotomy, I guess.
Sir, one query from my side. As the patient is around 60 years now, can we consider going for a first MTP fusion?
The client is not orthopedic. I don't want to create that kind of role. In case of severe hallux valgus or if rheumatoid arthritis or psoriatic that if the
I,
is very severe, fusion would be an option.
excuse me. Yeah. Yeah. No, I think you can go ahead.
That's what I mentioned, really. Basically, fusion does work in certain patients. Like I said, you know, like Ajoy said, rheumatoid arthritis or any arthritic patients or or severe deformities sometimes, you know, and you will not be able to get the joints, certainly.
So, anything to add, Aditya?
No, Dr. Kamlakar sir, your audio not visible, not clear, sir.
Fine. Yeah, is it fine now?
Yeah, but I think you have echo from that.
Yeah. Aditya, anything to add now?
No, not really. We'll go to the next.
Yeah, then we'll go with Abdul Ghafar's case. Right. I think we have the PPT of that. Can you share the Abdul Ghafar's case?
There is an audio coming from behind.
Hello?
Abdul sir, you share your screen.
Yeah. Is that fine?
Yes, sir, fine. Please go ahead.
Okay. So thank you, Kamlakar sir, Aditya bro, and the OSSCon organizers for the opportunity. So today I'll be presenting two of my cases on peroneal tendon pathologies. My first case is that of a 48-year-old female who had a twisting injury 3 months back, and she had been having persistent pain over the lateral ankle. And on examination, there was fullness over the lateral side, and she had pain at the extremes of movement. Her X-rays were the normal limits. She had tenderness along the peroneal tendon. So since she was having persistent pain and she was not responding to conservative management, we proceeded with an MRI scan, and the MRI showed a tear in the peroneus brevis tendon. So you can see the sagittal axle and the coronal cuts. So since it was persistent and was not responding, we decided to go for a surgical repair of the torn tendon. So this was a planned tendon, and the tendon was explored. So this is a long longitudinal tear seen posterior to the fibula, and an additional tear was seen on the same tendon just before the insertion. So I don't know how commonly you see this kind of a picture in the peroneal tendon. And it was repaired with an absorbable suture, and the retinaculum was closed, and that is what was done for the patient. So shall I present my next case also?
Sure.
Yeah, okay. So the second case is a 30-year-old male. He had a twisting injury of the ankle while playing football. At the time, he experienced a snapping kind of sensation, and he was having occasional pain, and the same sensation, the frequency of the sensation was increasing over the last few months. And so clinically, this is what was seen. So the diagnosis is quite obvious. An ultrasound scan was done, and the diagnosis was confirmed. So it was an unstable peroneal tendon that was subluxating. So we decided to stabilize the tendon as he was symptomatic. So this was the planned incision. The tendon was explored, and you can see the groove was very shallow. So we decided to go forward with deepening of the groove. It was deepened by using a making a by making a burr hole just beneath the groove with the help of a cannulator drill bit. It was further deepened with the help of a tape bender, and you can see the groove has been deepened. The tendon has been placed back, and the retinaculum was very well sutured by taking few transversus bites. So this is what was done. So, thank you.
I mean, peroneal tendons are very commonly seen, peroneal tendon injuries. But mostly, like, we always try conservative management. And I guess you might have tried that in the first case, and once it fails, then we go with the reconstruction or debridement and repair, right? And most of the time when you see, it's either the part of the ankle instability, so with the lateral ligament insufficiency or stretch out ligament and the peroneal tendon, both, right? So you repair the lateral ligament as well as you fix the longus and brevis, both of them, tendon tear. Mostly with the peroneus brevis, you see the lower lying muscle belly. So basically you exercise the lower lying muscle belly to prevent the overstuffing, of that area, decompressing that area, and you just excite the bad tissue and repair and tubularization. A number of times, like, it's very important clinically before the surgery that you check if the patient is a tendinous distally, and that was the case in your case with the proximal as well as distally. You extended distally, correlating MRI, so you were able to see the tear extending distally as well, right? So if you just make the mini approach, you might have missed that. So it's very important, like, you clinical examination with the MRI correlation. Number of times, like, if the peroneus brevis is not reconstructible, I do longus to brevis transfer, or sometimes with a bad tendon, both of them, you can do the FDL tendon transfer, right? So that can be done. The other thing very important of the calcaneal, if it's a varus heel, adding the calcaneal osteotomy, to prevent the vector off from this lateral area, that can be very helpful. And the groove deepening, it was pretty obvious, like, that you did. There are a number of ways of doing the groove deepening. I mean, in my head, like, I just opened the flap laterally, I scoop out the, cancellous bone and put it back. And the way you are doing also, that's number of people, they feel comfortable doing that way and decompressing. Most important part is, like, that number one, you don't damage the cartilage, So that's number one. And number two, you sew back the superior perineal retinaculum without making the over tightening or strangulating your peroneal tendon. So that's very important here.
Definitely the pocket wherein the tendon wants to go back in and out. We really need to remove that pocket. You see, otherwise you will have a room for the tendon to go back in there. If you don't do this very well, you will end up having a recurrence. So I think what you did, Abdul, was a very good job. I think again, you have to see what else is going on. Obviously you don't want to jump to that thing. Okay, it's dislocated and that's all he has. No, obviously that's there, but what else is going on? Is there a associated ligament problem or hindfoot alignment problem, as Dr. Ashish has mentioned? So you have to treat the whole pathology, otherwise they'll come back, you see, because sometimes they don't come just on their own. They come with other things. But I'm sure you have assessed those things. So, but commonly, those are the combinations. But sometimes if the if the if the tear in the brevis is small, you don't need to make it a tubular structure, you see, because if you look at the structure of the peroneus brevis, it's very flat. So if only a partial tear is there, you can just excise it instead of making a tube out of a flat structure. So
That's another thing which you should consider. Great job.
But I think we have come to the end of this session, sir. I'm extremely thankful to all the panelists and on behalf of OASISCon and to my colleagues, Dr. Aditya and Dr. Vamshi, who has been there with me. And to all the other panelists, Dr. Ajoy sir, Parthiban sir, Sundar Rajan sir, Rajesh Simon sir, who have been, I have been disturbing them here and there. And my sincere apologies also to all the panelists. I have been pestering you for the talk all the time with a messenger of gentle reminder. So thank you for bearing with us. And this, so that was the reason, because it's an excellent teaching. This thing what comes from all of you. So we had to pester you for the teaching to come out of you. So I've been after you. So thank you, sir. And it's been too late. Thank you again from my side and the OASISCon. Keep nothing more. Anything?
Meeting.
Thank you, Kamalakar, for organizing this. It must have been pretty difficult with this things going on, and you did a fabulous job. I think the electronics and everything worked very well. Sometimes they don't work very
Thank
well.
you.
I think the whole team, Kamalakar, folks with OASISCon did a fabulous job.
Best discussion I can think about, if it was in person, we couldn't have done this much discussion. No, that's great. You organized pretty good. Thank you.
Good. Thank you.
Okay, thank you all. Sure.
Thank you, sir.
Okay.
Thank you all.
Hopefully we'll see you all later.
Thank you.
Thank you.
Thank you.
Sure.
Thank you, Kamalakar. That was good.
Thank you, sir. Thank you very much. Thank you.
Sir, end the session, sir.
Yeah.
I stop the video recording, streaming.
Yeah, fine.
Okay, sir.